want me to copy it onto the hard drive?
It'll probably run better if you drag it to the desktop.
So, of course, she looks like me, so I don't know if that bodes well for her.
Is that the
But
file?
yeah, so that was sort of our
Looks like it.
middle of April.
Okay. And now we just want to take this out, right?
Yeah, if you want to eject that.
I'm not used to PCs.
Yeah, so are we going to switch the OTA?
Yeah, we'll switch Joe.
I think if you guys think,
It's not me. It doesn't make difference to me.
I think we'd be good because he kind of has a little bit of introduction and then
yeah, I think that's perfect. Good. So,
And then do you have an updated?
I don't. I think
Okay.
I'm just gonna kind of go with it.
Okay,
I'm going to sneak out this pop.
sounds good. Then let
Will
me.
you grab me one?
and then, what time should we invite people in?
Pretty soon.
Like in 5 minutes?
Yeah.
Okay.
Well, I mean, we said that we were going to start at 9,
Yeah,
so.
so we should start. in a
Yeah,
few
we shouldn't be
minutes,
too much after because of the live stream. People will be expecting. So you're going to go after the break then? Is that? Or were you?
I'm gonna just switch with Joe.
Okay.
So where Joe was, I'm gonna go.
All
So
Good morning, everybody. Welcome to I think it's our 6th annual Cochlear Implant Day with Experts. My name is Ruth Latevsky. I want to welcome you here today. I've been a professor at the University of Wisconsin-Madison since 2001, and I teach in the Department of Communication Sciences and Disorders, and I have a joint appointment in otolaryngology, which is our division where we provide services to people who have hearing loss, including cochlear implants. And so the partnership for today's program it's a really wonderful combination between our folks here at the Weissman Center, who really helped to put together this as part of a series of a number of days with experts that go on throughout the year. And also the Division of Otolaryngology, the Department of Communication Disorders, and I'll tell you about that in a minute, but I first just want to specifically thank Teresa Palumbo and Shelley Godard, who have done a wonderful job of really helping to put today's program together. So our sponsors, as I mentioned, include our partners, the Division of Otolaryngology, Department of Communication Sciences and Disorders, and we have sponsors today that include Cochlear and Captel, and our reps are just coming in and they would love to share information with you when we take a break. So I'm going to take just a few minutes to talk a little bit about the general scheme in which we operate here. We are on a campus that has been around since the 1800s, and if you read about the history of the University of Wisconsin, one of my favorite reasons why I'm here is the Wisconsin idea. It's a long and deep tradition surrounding the university, and the principle is that education should influence people's lives. We don't work or live in a bubble, and it should be beyond the boundaries of the classroom and the campus. So it's our job as researchers and professors to reach beyond the boundaries of the campus and to create events like today's event, where we are here for the community and we love this part of the outreach that we do. And so that's a really important piece of why I want to welcome you here today. And the idea is that education should influence people's lives, and the guiding principle for research, and we have about $1 billion of extramural funding on this campus. And so in health-related fields, what we really strive for is to identify new problems. We conduct research to understand and solve the problems. We educate our students, some of whom are here today, so they become clinicians and scientists using the state-of-the-art knowledge that we have. We reach out to our community, connect with industry, and identify new problems. And so it's a circle that spirals in new and wonderful directions from year to year. Here at the Weissman Center, we're dedicated to the advancement of knowledge about human development, specifically about developmental disabilities, and also about neurodegenerative disease throughout the lifespan. So we work with infants, children, adults, and with older adults as well. And an example is the work that we do on hearing loss and cochlear implants. And we have a lab here at the Weissman Center in which we do research on cochlear implants. We have about 25 people in the lab, and we support our research with funding from the National Institute of Health primarily. And I know some of you have been participants in our experiments. We work with infants, children, and adults, and it's been a real pleasure to have you be part of our lives. So the overarching goal here at the Weissman Center is what we call the 3 C's. We want to understand the causes, whether they're genetic or environmental or otherwise, consequences of the causes of issues and limitations or health issues for individuals, family, and society, and cures and treatments. And really, the span of research here is unbelievable. We have over 60 labs that do research on anything from stem cells to child development. We have clinically grade drugs and brain imaging. And in fact, I want to tell you that when I spoke here a couple of years ago, if anyone was here, you might remember I talked about a new neuroimaging method that is out there. We hope to get our hands on to be able to image people who have cochlear implants because magnetic resonance imaging is not safe. And so we just got the money to buy the equipment, and we're really excited to move forward. This is using functional infrared spectroscopy, so it's an optical way to image the brain. So hopefully next year we'll tell you more about it. So today's topic is cochlear implants, which results from progressive or sudden hearing loss. And the criteria are changing, as our experts today will tell you. It used to be that people had to have bilateral, severe or profound hearing loss. And what's really interesting as I've been in the field is the observation that the criteria for who receives a cochlear implant is changing to the point where we now see patients, it's not FDA approved yet, but we see people with normal hearing in one ear, deafness in the opposite ear, and they are candidates for a cochlear implant. Often it used to be to reduce tinnitus, but nowadays there are other clinical trials under which this is being explored. So the really important point I want to make is things are changing all the time, and the standard of care is changing all the time. Now, there are also interesting choices that a lot of patients make. Should I get a cochlear implant or keep using my hearing aid? When is my hearing bad enough so hearing is no longer helping me? I know a lot of you ask this question. And if I get an implant, what is the process like? Will I be successful? How often do I need to see my audiologist or speech-language pathologist? How much does it cost? Should I get one or two? And many, many more questions. And this family is really interesting. They've come here to participate in research from the West Coast because both of the children were born with profound hearing loss, as were the parents who were congenitally deaf and both sign and speak. But when their children were born, they decided that both children should get simultaneous bilateral cochlear implants by age 1. And then each parent got one as an adult so that they would understand what the process is like. And they have 6 implants in that household, which I think is fascinating. And the children really speak phenomenally. Their speech production is really fantastic. And the picture down here is of a completely different treatment approach. It was taken at the University of North Carolina of a child who received an implant in the brainstem. And so there's a whole new kind of advancement for people who cannot receive implants in the cochlea to go to higher levels in the auditory pathway, the brainstem being one target. So cochlear implants, in my view, and this is why I love to study what goes on in this field, is this is a hallmark of translational research. And the NIH talks about it that way. We are the poster child for taking engineering and bringing it to a level of treatment that's highly successful for our patients. And it's a beautiful combination of research, discovery, treatment, education, and outreach, which is why we're here today. And so, again, today is a collaboration between the Weissman Center, our hospital, and our audiologists and our surgeons, and my home department. And what I'd like to do now is introduce our speakers. Before I do that, though, I want to share with you that we decided to swap the order of our 2 invited guest speakers, Dr. Dunn and Dr. Roche. And the reason is we realized Dr. Roche, who I will introduce, is going to tell us about the background and more general issues related to cochlear implantation from the clinical perspective. And then Dr. Dunn is going to tell us about the research that she and her colleagues have been doing at the University of Iowa. And we decided the order was better, so we hope that you don't mind. Dr. Roche is a fantastic and unique example of what we call a clinician scientist. There are not many of them out there because by the time you get your MD and you do your residency, and he was the chief resident in his program, and you do a fellowship, and then you do a postdoctoral fellowship, you've had many, many years of training and education, and it's a huge commitment. Many doctors, are happy to treat patients. They're happy to have the clinical world, but to really carve out time to conduct research is something that I think is really unique, and I really highly value it. And we're very fortunate to have Dr. Roche, who's about to finish his first year here in our Department of Surgery Division of Otolaryngology. He's been a fantastic mentor to our students so far, and we're delighted to have you here with us. And please join us here for your presentation, and afterwards you'll take questions. Yeah, okay. Well, thank you very much. Are you going to do it from up there? Okay.
Well, thank you for that nice introduction.
There you go.
Thank you.
Okay.
Well, it's my pleasure to be here today. Thank you for coming. Hopefully I will provide some important information, as well as some history and sort of what a cochlear implant is, what it can do, why we would choose an implant over other types of hearing treatments, both osteoconductive implants, which I'll talk about, as well as intercochlear devices. So to start off, I don't have any disclosures relevant. Everything I'm talking about today is FDA approved, so there are some other things that are on the horizon that Dr. Latowski talked about, such as single-sided cochlear implantation for profound unilateral deafness that are not quite FDA approved. However, today I'll be just talking about the FDA approved, and that should be enough to fill the entire time. So just the outline, I'll be talking about just some generalities of normal hearing, and hearing loss, some of the treatment options, the concept of why someone would want to have an implant, and then intercochlear implants. Cochlear implants are the example of this, as well as osteoconductive implants. And I'll probably go a little bit faster with the osteoconductives so I can spend a little more time on the cochlear implants. So hearing loss can be thought of as an inability to detect and process sound into meaningful perceptions. In other words, it's more than just being able to take sound from the environment and detect it. You have to be able to turn it into meaningful perceptions. Dog barking, car backfiring, your grandchildren talking. And not just talking, but what words are they saying to you? Can you use it in a meaningful way? So it's more than just the detection of sound. Some estimates have said that up to 5% of the world's population, or 300 million people, suffer from disability related to hearing loss. And in our own country, some work that's been done by Frank Lin has estimated that it can be as common as up to 20% of the population when you consider both uni and bilateral hearing losses of all different types. So there are three structures that we think about, especially surgically, when it comes to hearing. There's the outer ear and middle ear, which is the ear canal, the eardrum, little hearing bones that help take sound energy from the external environment and get it into where it can be turned into perceptions. There's the inner ear, or the cochlea, which is involved in taking that sound energy and transitioning it into electrical signals. And then there's the central nervous system, of which the auditory nerve is a key component for cochlear implants, which then takes that information. There is some processing that occurs, but mainly transmits that into the central nervous system structures, where it can begin to be processed and turned into localization, dogs barking, and perceptions that people are going to find useful. So when we think about the outer and middle ear, again, the focus is really to transmit acoustic energy, so sound waves, pressure waves, get those into the inner ear where they can be turned into electrical signals. And so this involves the eardrum, the ear canal, these little hearing bones here. And if someone has a disease process which impacts any of these structures, then a conductive hearing loss results. In other words, sound can't get in. It cannot be conducted to the inner ear. And this would be an example here of someone with quite a lot of reasons for conductive hearing loss. There's a hole in the eardrum. One of the hearing bones has been shortened. Another hearing bone has been partially dissolved. So this person may have a perfectly normal cochlea, but is not able to get information or sound energy into where it can be turned into electrical signals. Once we get past the middle ear and the external ear, the cochlea is the next part of the hearing process. And this is found just connected to the hearing bones. This is a cross-section of it. It looks like a snail, and that's where the term cochlea comes from. And then when the sound comes in, the inner ear bones vibrate fluids in the inner ear, and those vibrations move little detector cells, which are depicted right here, the inner hair cells as well as the outer hair cells. And those hair cells take that pressure energy and turn it into electrical signals, which then are transmitted through the acoustic nerve or the auditory nerve into the different processing centers of the brain. If someone were to have a damage to either the cochlea or the nerve, a sensorineural hearing loss results, In other words, sound might be able to get in, but it can't be turned into signals, and it can't be transmitted to the brain to be utilized to be turned into auditory perceptions such as music and sound and voice. So when someone thinks they have a hearing loss, or when we think one of our family or friends have a hearing loss, the first step is really evaluation, because the type of the hearing loss, whether it's a conductive loss, can't get in, it's a sensory neural loss that can't be detected or processed, as well as the configuration. Is this just in the low frequencies? Is it in the high frequencies? Is it a combination of all the frequencies? Is it a combination of both conductive and sensory neural? All plays a part in what treatment options might be available to a patient, and how we can then choose which treatment options are the most effective for that person's communication goals. The key and critical portion of this is the hearing test. There's really no way around this. This is the most important part of the evaluation process, and it's done by very expert providers that are able to do very sophisticated testing to parse out the different parts of hearing and where the defects likely are occurring. Once someone becomes a candidate for hearing restorative surgery, oftentimes medical imaging to sort of, as best we can, determine if there's an anatomic reason for this and whether or not we can take advantage of that information in treatment. And so why that becomes important is that sometimes there are conditions that may need to be treated. The hearing loss is a result of something that is maybe a bigger issue for the patient, of which hearing loss is just one symptom. So this is an MRI of a patient who had hearing loss, but unfortunately had a very large tumor that we were able to successfully remove without any long-term sequelae. But the point is that hearing loss was the problem. And so a medical evaluation by multiple different types of professionals is important to ensure that someone who is going to get treatment is going to get that treatment safely. So the hearing test really has two main parts. There's sound, and this may be just my simple surgeon way of thinking about this, but there's really sound detection, which is depicted by the audiogram here. And this is where people are typically being presented with a tone. They have to push a button, raise a hand, provide some feedback that they can hear that tone. The low frequencies, so the bass, is typically located at the upper left, and the high frequencies is located here on the right. And then this on the y-axis is really sound intensity, and it's plotted a little bit differently than most plots, but the point here is that this would be essentially normal hearing up in here, and this is really profound hearing loss down in here. And so people can have lots of different types of configuration. But probably key and critical to cochlear implants is the clarity of sound. How easily, so even if you can detect the sound, if you can't turn that into meaningful perceptions such as words or voice or music, then many types of treatments are not going to be effective. And so this right here is demonstrating a patient who, even though they can detect the sound, they are unable to turn any of that sound into meaningful perceptions. So this person is getting 0% of the words that are being presented to the patient correct. So they really have a quite profound communication deficit from their hearing loss. So hearing loss can come in a lot of different varieties. This is, again, another example of an audiogram. Normal hearing is oftentimes thought to be somewhere between 20 and 25 decibels, depending on the scale. And that as we have progressively larger losses, it goes from a mild to a moderate to a severe hearing loss. Just to give an example, these are typically pretty quiet sounds. Normal conversations are typically occurring somewhere in the moderate hearing loss region, so 50, 60 decibels. And really, profound hearing losses, the volume here is really rock concert, a jet engine as you're at the air runway. These are really very loud sounds, and it actually can cause damage if you're exposed to them for a significant period of time. Most individuals who will be a cochlear implant candidate are typically going to have hearing loss that's in the severe to profound category. Not all, but most. So treatment, not surprisingly, there's lots of types of hearing loss, there's lots of places where there can be a problem, can really be, is really tailored to the type and severity of the loss. For people who have mild to moderate losses where their communication is either very minimally affected or moderately affected, oftentimes different types of behavioral interventions can be effective. So for example, if you have a mild hearing loss, sometimes you may just elect to just observe this, and we'll just continue to see, does this progress? Does this not progress? Sometimes seating arrangements are helpful. Sitting in the front of the classroom, sitting with the person who's talking to the side of your good ear might be all that is necessary for some individuals. And there's a variety of personal assistive listening devices they're ever expanding every day that people can use that don't necessarily require a visit to a hearing professional. On the other hand, for people who have moderate to severe hearing loss, oftentimes their communication is affected, and hearing aids are the mainstay of treatment for the majority of individuals. Not every individual, but the majority. And the one important concept is that this was going to utilize the entire auditory system. These are really going to present sound to the ear in a louder fashion, and then take advantage of the remaining structures in the ear in their native state, whether that's diseased or normal. So these utilize the whole system. which is really different than an implant. Most implants are going to be bypassing a portion of the system. So if, for example, if someone has a conductive hearing loss, sound can't get in, we bypass that by directly stimulating a presumably normal cochlea. That is different than a cochlear implant. In a cochlear implant, the patient may have a normal external ear, but it's the cochlea that has been damaged, whether it's genetic or toxins or trauma or whatnot. And so the cochlear implant is going to stimulate, after being placed within the cochlea, this nerve directly to bypass the diseased cochlea and get perceptions of sound into the central auditory system. So for cochlear implants, so most of the time these are being, for people who have a very severe to profound hearing loss that results in a communication deficit, this is a very effective treatment strategy. Most of the time, hearing aids have been trialed by individuals, but they have been found to be ineffective. In other words, you may be able to detect sound, maybe, not always, maybe, but it's not clear enough for you to understand speech and language and other things in your environment at a level that is satisfactory for the patients. And so this allows direct stimulation of the hearing nerve, because in most cases, the majority of the damage and the majority of the loss is occurring in the cochlea, and there are enough residual nerve fibers that are healthy enough to accept this stimulation to allow for meaningful perceptions once people have had the device and they've had a chance to practice with it and learn how to use the device appropriately. There's essentially two components to the device. There's an external speech processor, which is depicted here. This is a speech processor as well as a telecoil, which then transmits. So in other words, this looks like a hearing aid. This is where the microphones are. There's a speech processor. It takes sound in the environment, breaks it up into its different components, and then transmits that to an internal device that sits under the skin, right here. And there's a little electrode array that gets threaded through the mastoid, which is a portion of the ear, through the back portion of the middle ear and into the cochlea, and then can stimulate the nerve of the cochlea directly. These two devices are held in place by magnets. In other words, there's a magnet in the internal device and a magnet on the external device, and they're north and south, and so they tend to want to attract, and it holds it in place. So in most cases, at least for cochlear implants, in all cases, there really isn't anything coming through the skin. So this allows people, when they're not wearing the external device, to be able to shower. If they wanted to, they could use a swimming pool and go swimming. They couldn't do it with the external device in place, but it is completely sealed underneath the skin. And they communicate via radio waves. In other words, the internal device is actually powered specifically by energy that's being used through radio waves. So the surgery is gone through a variety of modifications over the years. This sort of gives a general overview of the contemporary surgery. There's an incision that's made behind the ear. There's a couple of different types of incisions, either a little S-shaped incision or a curvilinear incision. This exposes the bone of the skull. The cochlea, which is where the actual electrode array goes, is then exposed by removing carefully a portion of the mastoid bone, which is tolerated very well by patients. This is not something that's key and critical for normal function. And then we can get access to a little area of the cochlea here, which then allows us to very carefully slide an electrode array into the cochlea. Now, there are a variety of ways that this can be done in different circumstances. This just depicts one way where the bony opening has been made. But the electrode is really slid into the cochlea and curls around this snail shell-looking structure. And after all this is done, then the device is then fixed in some capacity. And there are a whole host of ways this can be done. Used to be that people would use titanium and mesh. Some people have used sutures. This is depicting 2 screws and some sutures. Other people now are making they're just actually sliding under a pocket of skin to hold it in place. But the point is, this internal device sits behind and above the ear, and so it's away from the external portion of your ear canal. So who is a candidate for a cochlear implant? Well, FDA, these are approved for adults and children at or greater than 12 months of age. There's no real upper limit per se. I've implanted individuals as old as 94, and they have done quite well with their device. So if someone is healthy and is motivated to get one of these devices, there really doesn't have to be an upper age for surgery. And for children that are younger than the age of 12 months of age, we have implanted individuals younger than 12 months of age, and in fact in Europe they're implanting children as young as 6 months. That has not been FDA approved here, so I won't talk about that, but the point is that we can implant individuals across their whole natural lifespan, and people are getting benefit. Most individuals have a profound or moderate to profound hearing loss, which would mean little X's and circles here for thresholds that are somewhere in this region. So that's a pretty significant communication deficit. And more importantly, they've trialed hearing aids and they've not gotten significant benefit. In other words, even if you have sound detection, it's not clear enough to get any meaningful benefit. At this point in time, there are 3 FDA-approved manufacturers that are available in this country: Cochlear Americas, Med-El, and Advanced Bionics. The devices all function fairly similarly. There are differences that are not insignificant as far as when you might use one versus the other. And each company now has a different variety of electrodes that can be utilized for different types of hearing losses, for different types of cochleas, and etc. They really come in 2 main types. There's a pre-shaped, which, in other words, and I'll show this in a second, the electrode, once placed, takes the shape of the cochlea in order to help improve stimulation, as well as soft and flexible, which are generally considered to be lateral wall. These are electrodes, when they're placed, they actually take the shape of the cochlea as opposed to conforming to a shape, and I'll explain that in a second. So recent innovations with cochlear implants over the last 10 years or so there's been a real push to try to improve the patient-prosthesis interface. In other words, how can we get the patient and the device to interact optimally? How can we improve how well people are performing with these devices? Additionally, we're trying, and as Dr. Dunn will be talking about, but what I learned extensively at the University of Iowa is hearing preservation cochlear implantation, where if people do have a residual level of hearing, even if it's not giving them functional benefit from a communication standpoint, if we save that hearing, it may give the patients benefits in other aspects of hearing. And then lastly, MRI compatibility, which is something that, at least traditionally, cochlear implants have been considered to be MRI incompatible and I'll talk about that, and that is no longer the case. So for the patient prosthesis interface, one of the concepts that's gotten a lot of attention recently is trying to bring the electrode array, what is actually providing the stimulation to the nerve, and the nerve into close proximity. And there's some reasons this might be beneficial. There are some designs that I've showed here, both from Advanced Bionics and Cochlear Americas, which these are the devices after all of the stylets have been removed. In other words, they're held straight, they're placed into the inner ear, and then a stylet of some type is then removed, and then the device conforms to the shape of the snail shell. And the idea here is that as opposed to having an electrode that's found out here at the lateral portion or the outer portion of the cochlea, this being the hearing nerve, the electrode is really in quite close proximity. The benefits of this is that you can use lower electrical currents to stimulate the nerve. The idea being that if you have to use a larger electrical current, there's a more chance that current will spread and it will degrade the speech capacities that the device is able to give, because there's information crossing over into different processing channels. On the other hand, at least in most experiences, most of these devices do not offer a reasonable chance of saving hearing. Most of the time, these individuals, if they have any residual hearing that is left before surgery, after surgery, that hearing is typically compromised significantly. Not a trivial thing. So does this actually matter? Well, this is some data that was presented at a paper in 2013 where they, through a very complicated series of experiments and CT scans, they actually looked to see, well, if you can measure how close the electrode array is to the inner ear, does this make a difference with speech perception? So very simply, over here is farther from the nerve, here is closer to the nerve, down low is worse performance, and up here is high performance. And there's a trend that shows that if you, at least in this study, if you have an electrode array that is closer to the medialis or where the nerve is, you do tend to have a slightly better speech perception. On the other hand, a paper that was published in 2014 out of the Vanderbilt group looked at, for individuals that were having all different types of electrodes, what were the factors that were most likely to predict good speech and language outcomes. And what they were able to find, and we'll just focus down here, was that most of the time the lateral wall or soft electrodes tended to stay in the original place where they were put. In other words, you put these electrodes in, they don't tend to bounce around the cochlea and damage structures. Whereas the pre-curved electrodes, whether they were from Med-El or from Cochlear or from Advanced Bionics, tended to have a much higher rate of transitioning from one part of the inner ear to the other. And that actually was associated with, if you could not transition, not cause damage, this was associated with better speech and language. So practically speaking, the jury is still out. Lateral wall electrodes, pre-curved electrodes. The reality is that there are reasons to pick one of the two, and there probably isn't strong evidence to say you should have one or the other at this point. There are patient preferences that typically are going to, and hearing loss and configuration that play a larger role. So hearing preservation cochlear implantation. So many patients, and this is depicted here, will often have a very profound hearing loss in the frequencies that are associated with speech and language, yet they will have relatively normal thresholds in the low frequencies. And this is, can be important for sound localization, music perception, and the finer perception of different sound stimulations. However, as I just mentioned, many cochlear implants result in the loss of this residual hearing. Well, what if we could try to save this? And so, where I did my fellowship and in other places around the world, there was an active research interest in trying to come up with different types of strategies and electrode designs to try to save what hearing is available. And so this person right here, just based on traditional FDA criteria, would not actually be a cochlear implant candidate. However, with shorter, thinner electrodes, which are depicted here, and some modifications of technique where we try to do this in the most atraumatic way as possible, hearing can often be saved. And so just to compare, this is what would be considered the straight electrode from Cochlear, or the 522, which is a lateral wall electrode. It's soft, it's flexible, but it's long, and all the contacts are spaced out. This is what's called the L24 electrode. The point here is that it's shorter and it's thinner than its other counterpart. This is designed specifically to avoid trauma to the parts of the cochlea that may have residual hearing. This is the Med-El device, and again, this is their standard electrode. It's bigger, it's longer, versus the electrode that's designed to try to preserve hearing. And the idea is that a smaller, thinner electrode is going to cause less damage. It's less likely to injure structures by bouncing off things because it's smaller. It can conform more appropriately to the confines of the cochlea. Well, that's great. Can we actually save hearing? Well, these are two studies, I think, that highlight that we can do a pretty good job of this. So this is a study looking at the Med-El device, published during my time at the University of North Carolina in my residency. And it really shows, if you look at the blue here, which is basically how well people can hear in the low frequencies before they have surgery, and all of these dots down here, which is how well they hear after surgery, most patients are losing a little bit, but they're maintaining a significant amount of low frequency hearing, at least with this electrode. Over here is a study that came out of Europe by Dr. Lenartz, and this shows that very similar. This is using the Cochlear Americas, or Cochlear product, which is the L24. The red boxes here represent their pre-operative, pre-insertion hearing, so good in the low frequencies, not so good in the high frequencies. And this is a year after surgery, again, showing that while there may be a slight loss of some of their hearing, most people are able to preserve the majority of these structures, or majority of their hearing. So hearing can be saved. So, but does it actually matter? So we've done a good job. We've designed well, I haven't done it, but many people have designed really brilliant electrodes, come up with very great soft insertion techniques. But does this actually make a difference from what patients experience and how they perform with these devices? Well, this study here, again, looking at the pre-operative word recognition score and then comparing it. So these are individuals that save their hearing and they're still able to have word perception even with an implant in place after surgery. If we look at how they perform with their implant, which is the red bars here, and no acoustic stimulation, they perform much better. And they perform even better once we add back the capacity to use the residual hearing. So if we can save hearing, it is a meaningful thing to try to save. And this is with the Med-El device. And of course, at the University of Iowa, I was very fortunate to be involved, not directly, but watch a lot of this work evolve with Dr. Gantz and Dr. Hansen and Dr. Dunn. This is looking at the L24 device. This is a multi-center U.S. trial where sort of showing here that this is all the black bars represent their preoperative word recognition scores. The blue bars here represent how well these individuals are doing when they have their device and they have their hearing aid or their modified hearing aid in place. And so you can see that these individuals, if we can save hearing, are doing significantly better than they were before they had their surgery. So we can save hearing, and at least the data would suggest, and many patients would suggest, that they are doing very, very well with these devices. So lastly, cochlear implants and MRI. So as I mentioned earlier, these devices are held in place by magnets. And if you remember back from high school science, if you put one side of a magnet against the same side of a different magnet, they tend to push each other away. Well, the same thing happens with MRIs. An MRI uses a very powerful magnet in order to acquire images so that we don't have to use ionizing radiation. Ionizing radiation is what happens with CT scans and chest x-rays and etc. So when you put a cochlear implant in an MRI machine, number one, the MRI is going to put a large force in that magnet, and number two, it's going to cause a large shadow over and distort all the images. So number one, you may not see what you're looking for, and number two, it may not be meaningful even if you can see it. Additionally, this can cause some pain, and then there have been reports of magnets actually being pulled out of the implant, flipped its polarity, and it can cause some significant injuries to the patients. And so for many, many years, a cochlear implant was a contraindication to an MRI. And MRIs are becoming much more common in medical evaluations because they don't have ionizing radiation. So the device manufacturers are acutely aware of this, and they have come up with different strategies to solve this, so that if you have a cochlear implant, you can get an MRI. There are stipulations. These are called MRI conditional, which means that under certain conditions, an MRI may be able to be obtained. So the MED-L device, which is depicted here, they have a rotatable magnet, which actually will then realign to the magnetic field of the MRI, meaning that the forces imparted are advantageous and they don't actually tend to push on the device. The magnet will spin. So up to 3 Tesla, which is the most common MRIs performed today, Tesla is a strength of a magnet, these devices have been FDA approved. And they don't require any special wrapping of the head, any special devices. And so this can be a good option for patients who may need to have MRIs in the future. The Cochlear Corporation, their profile device, they have their magnet they take it a slightly different strategy. Their magnet is removable. In other words, with a second smaller surgery, we can make an incision, we can take the magnet out if that is needed. Or they have a special little device that can be placed over where the magnet is, held in place with a head wrap to help hold the magnet in its correct orientation so that it doesn't shift with the MRI. And these, again, have been FDA approved up to 3 Tesla. In Advanced Bionics, they have, with their devices, their magnet is removable, and so if you remove the magnet, both 1.5 and 3 Tesla MRIs can be utilized. And if you need to leave the magnet in place, in other words, you don't want to have a surgery to take that magnet out, then the head needs to be head wrapped to help prevent migration, etc. So the take-home point here is that while MRIs have traditionally been considered a contraindication, in the last few years with developments and advances by the companies, these can be often safely obtained for most patients. Okay, so that's cochlear implants. So just to be clear, these are devices that are placed into the cochlea. Now I'm going to transition to devices that are not placed in the cochlea and are actually placed in the skull. 1 minute? Okay. I'll keep a long story short. Most of it is that the concept of this is that someone has a normal cochlea and that we are bypassing their external ear with an implant that receives vibratory stimulation from a processor. This can either be connected with a device that comes through the skin, 2 magnets that actually one vibrates on the outside, vibrates the internal one, or with the Cochlear Corporation's device, these can be used, it can vibrate the skin without any type of an implant. And oftentimes we'll utilize these for individuals who are too young or don't have enough bone thickness to accept an implant. So hearing aids are usually pretty effective for conductive hearing loss, so why would we want to use these devices? Well, for people who have a normal cochlea, normal inner ear strut function, but they have problems with their external ear with drainage, or with maybe they don't have an ear canal. For example, either we've taken it out because they've had a big cancer that we had to remove, or they were born without an ear canal, which does happen. A conventional hearing aid is not effective. So who's a candidate? So you have to have essentially normal and near normal cochlear function with a conductive hearing loss, and that's really just because these devices don't have enough power to be able to stimulate a cochlea in a meaningful way once you start having a moderate neurosensory hearing loss. So there are limits to what these devices can accomplish. And then very quickly, people are using these devices now for single-sided deafness. So for example, someone has a profound hearing loss from a tumor, they've had trauma, there's some reason one ear has been their hearing's been completely lost. What you can do is put an implant on their bad side, which will then send the signal through the skull to their good side. It doesn't replace the hearing on their bad side, and it is not a cochlear implant, but it can give meaningful access to sounds that are on the poor side to the sounds that are on the good side. They are perceived on the good side, but it gives you better access to those sounds. And there is some data that suggests that maybe this is maybe better than some of the other types of hearing aids, but that is controversial. There's an evaluation process. Essentially, you need to be evaluated, determine you have a hearing loss. You need to see a specialist here, wherever you decide to get your implant, that can determine whether or not you actually meet implant criteria. You have to be a surgical candidate and tolerate the surgery and the placement. Once you undergo surgery, then there's usually a 1 to 3 month wait before we can use these devices, depending on which device we're putting in. And then oftentimes, people are coming back to get their initial programming, and they're coming back every so often. Usually it's every couple months in the beginning, and then once people have habituated to the device, at least once a year to program, make sure the devices are still functioning properly. And we offer a comprehensive we have a comprehensive panel of experts, researchers, surgeons, and medical professionals here at the University of Wisconsin. We offer both intracochlear and interosseous implants, and we can treat people from infants all the way up to 90-year-olds and beyond. So thank you for your attention. Sorry if I went over. I'm happy to take any questions now or at the panel. Sir.
Can you tell me what the current Medicare requirements are for word recognition?
40. It's Medicare's requirement.
In order to allow cochlear implants.
Sure. So the question is, what are the current Medicare requirements to pay for getting an implant? And it's 40% or worse in the best data condition. And that's a little bit more open-ended than many of the other types of insurance criteria, but 40% or worse in their best data condition. That might be single ear, might be both ear, and they don't specify what type of testing, but 40% or worse.
So that's been liberalized over the years, hasn't it?
It has been. And in fact, there's currently a clinical trial going on right now to look at expanding that to an even higher level, to up to 60%. Any other questions? Okay. Any questions? Comments? Tomatoes? Sure.
So now you have the different devices. Obviously, you don't change the electrodes. So if you start out, say, with a cochlear, you always have a cochlear, or do a processors compatible.
Across company?
Yes.
Not that I'm aware of. So typically, when you choose your internal device, that's the company you're going to be working with, unless for some reason the device has a defect, it gets damaged, it has to be removed for some reason, and then it gives you a chance to choose a different company. But then you'd be tied to that company, at least at this point. Any other questions? Okay, well. Oh, sir, go ahead.
Another question.
Sure.
Has there been any progress in musical recognition through
That's an excellent question. So music is, so the question is, has there been any progress in music perception? So I don't want to give, and then maybe I should have stated this outright, cochlear implants do not give natural hearing. They give back the capacity to understand speech and language. They sound different than most of us, what we would consider to be our native hearing state. Oftentimes we're trading the loss of some of the fine structure, which is what allows us to perceive music and prosody of speech, for the capacity to be able to communicate. But there is active research that's been going on at many institutions trying to come up with both processing strategies, in other words, how can we stimulate the devices that are currently there in an advantageous way to gain some of this that we have lost. And then, of course, people are also looking at coming up with entirely different types of cochlear implants, that optical cochlear implants, implants utilizing thermogenetics. But the idea is that to provide more channels of information so that all of these finer points of sound can then be processed by the nerve. And so people are making progress, but it's slow going, to be honest about it. Go ahead. It's variable. They're warranted. Each company has a different warranty for these things, but they can last 10, 15, 20 years. I mean, there are people that have had implants, I know at the University of Iowa when I was there as a fellow, that had them for 25 or 30 years.
They estimate that cochlear implants should last 70 years. So they don't, I mean, even though there's a warranty of 10 years, that's manufacturer defect type of warranty, but there's no real idea on if you get a cochlear implant, you can expect in 15 years to have it removed. That's absolutely not true. We hope that they can last a lifetime.
Sir?
I don't know if this is in the scope of your presentation, but is there a relationship between working with a hearing aid and a cochlear and a hybrid kind of arrangement?
I'm sorry, could you repeat the question?
And in terms of, is it possible for someone to have a cochlear implant on one ear and a hearing?
Oh, yes. Yes.
How
Often.
does that work? I mean, it seems like two different technologies.
There's no question it's bimodal in the sense that you have, well, it depends. If you have a hybrid device where you are utilizing both acoustic and electric stimulation in one ear, and then acoustic stimulation in the other ear. It can take some getting used to. Commonly, people who've had single-sided implants, for example, single-sided deafness, who have essentially normal hearing in their other ear, they tend to like their native hearing much better. But people, depending on their overall health and motivation, do learn to use both of these types of different information, and people do better. There's some studies that Dr. Lutovsky has been working on, looking at how well do individuals with a single-sided implant on one side and normal hearing on the other, how well can they localize sound, and the individuals are doing better than they were without the device. So there's no question the brain is able to accommodate this. Go ahead. Absolutely.
And interestingly, the cochlear implant companies are now joining with hearing aid companies to develop strategies for the two ears to work better together. So, for example, Advanced Bionics is owned by the same company of Phonak. So if you have a Phonak hearing aid, Advanced Bionics is owned by that company. So they've developed ways for the cochlear implant and the hearing aids to work better together. So some of the same technology you use can be utilized for both of your ears. And so Cochlear is also working on developing a relationship, or they have a relationship with Resound. And so some of the technologies that the cochlear implant uses can be utilized for both the cochlear implant and the hearing aid.
And there's a company in Europe called Oticon that has a device that's available there called the Neuro device. Oticon is a big manufacturer of hearing aids here. So this is something that is actively being researched and invested in by industry.
Yeah. And I'll also add that the hybrid device, so those patients use a cochlear implant and a hearing aid in the same ear. So those low frequency sounds that Dr. Roche was talking about still get amplified with a hearing aid, or what we call an acoustic component that is attached to the cochlear implant. So that cochlear implant is essentially providing low frequency information through a hearing aid and high frequency information through that electrical channel for that device. The preservation of that low frequency hearing really helps with music. That was one thing that you talked about. And so that's one thing we know about preservation of hearing is it still allows patients to have timing, which is so important for music perception. And so that's one big reason we want to try to preserve any residual hearing you have, is so that you can still enjoy music.
I have a music-related question. I have a cochlear implant for about a year and a half, and the second one with an acoustic component for about 6 months. And I've been a professional musician, and what drives me crazy is I used to have perfect pitch, and now I have very poor pitch. But is that because in the brain, when you had perfect pitch, each individual nerve cell registers pitch, and so now the implant stimulates a bundle of nerves, and so the pitch is not as pure? I mean, that's sort of what I've come up with in my own head, is why the pitch is so off.
I mean, sure.
So first, I'm sorry that you lost your perfect pitch.
Yeah.
It must be frustrating. And it's kind of what you were saying, which is that when you have acoustic hearing, you have thousands
Yes.
of auditory nerve fibers and thousands of hair cells.
Right.
And each
And that's one of the things that there's active research looking into improving the number of information channels that can be delivered by cochlear implant, with the idea that, and so there's some research going on, and we had a gentleman here give us a talk about using optical cochlear implants. The idea that the energy that you are able to provide to the nerve is so much more precise than can be done with the current strategies. There's also hair cell regeneration, and some people have talked about actually designing hair cells that may be able to then specifically, and nerve cells that may be able to specifically respond to different types of stimulation. But these are things that are very, very much in the research phase and probably won't be ready for medical decisions for many, many, many years, if ever. But it's something that we're actively, the entire hearing science community, from physicians to researchers to industry, is looking to try to improve the capacity to get more independent channels of information, more nerve fibers, essentially. Any other questions? I think there's a question.
I was wondering, assuming there's no trauma, if studies have shown that there are any side effects to the brain by long-term cochlear implant users, specifically those that were implanted as a child and go through the teenage years, the growing process. For example, dizziness or nerve twitches or things like that happen.
So there's no question that so imbalance is typically uncommon. If people have imbalance after surgery, it's typically self-limited. It's not maybe due to the fact that the balance system is connected to the inner ear. So the balance detector cells and it's called the membranous labyrinth, is connected to the scala media, which is where the hair cells are. And so those are connected. So by putting an implant into a space that is at least connected can result in some injury to the balance system. Most people compensate from that without any problems, if that's the case. And it's usually, most people are having, if they have imbalance or dizziness, it's usually only several days after surgery. There are some patients that have a profound vestibulopathy, but they are uncommon, very uncommon. What we do know is that especially with children, is that there's a critical period where if they don't receive adequate and meaningful auditory stimulation, that they will not be able to then use that part of the brain for sound processing in the future. And so that there is a lot of literature that actually supports the idea that the longer you go with deafness, the overall worse the performance of the devices are. And so almost to the converse of what you're saying is that the benefits to the brain from a cochlear implant are usually very high relative to damage that's caused by placement of the device. And we don't fully understand what's happening in the cochlea when we put these implants in. Most of the information is being gleaned from animal studies or histologic studies for patients who have donated their temporal bones to different temporal bone repositories, and a lot of this is inferential. We know that individuals definitely can lose their hearing, and the assumption is that as the device goes in, it's interacting in a way that's disadvantageous. But this is an active area of study of trying to find ways to prevent that damage. But for the most part, especially when it comes to children, the benefits are very significant, and not having the stimulation can be quite deleterious in the long term.
And just to add on to what Dr. Roche was saying, we did a study at the University of Iowa. So we implanted the first child in 1987 with a multi-channel cochlear implant. We've been following him now still to this day. And so this child is now 34 years old, and he did just fabulously. And so he's had no
think what we'll do is take a short break now, but I want to really thank Dr. Roche, and please either save your question for our next round, or you can come up to any of our experts and talk to them during the break. Thank you very much. Thank you very much, everyone, for your attention. Nice job. Thank you so much. Yeah. who in my mind is another example of a fantastic clinician scientist. Dr. Camille Dunn received her education in the field of communication sciences and disorders, audiology and speech. And she's a perfect example of a clinician scientist because unlike the surgeons, this is where the boots are on the ground in terms of people who really treat the patients day to day. Dr. Dunn is the director of the Cochlear Implant program at the University of Iowa. As many of you know, it's one of the biggest centers for cochlear implants in the country, if not in the world. And what's really amazing about their clinic is that they participate in so many clinical trials. So a lot of what we have learned about things like the hybrid device, or could you combine a hearing aid with a cochlear implant in the opposite ear, or some of the newer studies with people who have single-sided deafness, which is where we have new collaboration. So we will be bringing people from Iowa who are implanted there to participate in research here and vice versa. And so this is going to be a really nice thoroughfare between Madison and Iowa City. And so you have heard Dr. Dunn answer a few questions, and she's now going to tell us about some of her newer research as well. Thank you so much for being here with us today as one of our experts, and we'll take questions after your presentation as well, and really looking forward to your talk.
Thank you, Ruth, for inviting me up here. I'm so excited. I know Joe talked about his didn't have any conflict of interest or anything to disclose. I, on the other hand, am from Nebraska, so I'm a Husker fan. I work at the University of Iowa, so I've translated kind of into a Hawkeye fan, but now I'm talking in Badger country. So for me, that's a conflict of interest. Okay. So, I came here today, and I think in the program it talks that I'm going to talk about ecology. And ecology is how our environment affects what we do, what we hear, how we function every single day. But, I really appreciated your questions that you had after Dr. Roche's talk. And so I kind of thought I would change up my presentation just a little bit, or totally, and give you guys a little bit more information on some different topics, and then take questions on it. So if this presentation is kind of one that I pulled up from outer space and then brought in to give to you guys today, if it doesn't seem quite organized to what you want, I was kind of going in and taking things out and putting things in. So we're going to make this work though, okay? So as Dr. Lutovsky said, I've been at the University of Iowa for about 15 years, and during that time I have been able to participate and take part in a lot of the FDA clinical trials. Believe it or not, this hybrid hearing preservation study that Dr. Roche talked about a little bit ago took 15 years to go from initial thought to FDA approval. 15 years. And so that is, for me, that seems like a very long time, but we've been working on it, and I think, when I look at that, I'm really glad that the FDA doesn't just let everything in the door and come out to patients like you. They really make sure things are safe. They really make sure things are effective, and my experience with that clinical trial definitely showed that. So I'm going to talk a little bit about some of that information that went to the FDA that showed effectiveness of cochlear implantation. Hearing loss, this was a statistic in 2015 that said those suffering hearing loss will exceed 700 million. That is huge. And 1 billion by 2025. And then the World Health Organization estimated that hearing loss is more prevalent than any other disabling condition. Now we look at that and we think, why do we have so much trouble then with insurance?
why don't they cover hearing aids for people? Why do we have to go through so much red tape when it's the most disabling condition? I can't answer that. I wish I could, but certainly I think these statistics are really important. A lot of people with hearing loss are unserved or underserved. Unserved means they're not getting services. They might not understand that there are types of devices out there that might help them. Or underserved. Maybe they're underserved because of lack of reimbursement, insurance issues. And so there are a lot of things that go into hearing loss in these statistics. A cochlear implant, we had a really nice summary of what this is, so I'm not going to go over a lot in depth on it, but it's a prosthetic device that stimulates the auditory nerve electrically. It's used for individuals who have severe to profound hearing loss, and they don't receive a lot of benefit from their hearing aids. And what we hope is that the cochlear implant will provide better auditory perception, improved speech production, and certainly for children, improved language development. Okay, those are the three big things that cochlear implants, the purpose of them. But we've heard a lot today about the importance of cochlear implants for other aspects of our life, music. And so one thing that, when we were talking about this is what cochlear implants were developed for. They were developed to help people understand speech. And so I think there were other components of our life, localization abilities, music, enjoyment, are things that when cochlear implants were first being developed weren't the forefront of the focus. It was to help people understand speech. And so now that we have a really good understanding that cochlear implants help people understand better, now they're looking at these from different perspectives. Localization ability, which is the ability to be able to understand where sound is coming from, and music enjoyment, which affect our lives. So a little bit of history. Actually, cochlear implant research started clear back in 1790 by this guy, Alessandro. I wish I had a beautiful accent like I should have for that name. Volta. He first stimulated the auditory system electrically. He connected a battery of 30 couples to 2 metal rods and stuck it in his ear. Sounds like a brilliant thing to do or not do. And believe it or not, he received a shock, and then he heard kind of a crackling sound, and he said it sounded like some paste had been boiling in his ear. So needless to say, that stopped all research until the 1900s, where 2 French researchers finally decided to collaborate, and they implanted the 8th nerve stump, like right over here, kind of a picture of that, in a patient who had bilateral temporal bone resections. Okay, and that patient was able to hear sound. Then in 1964, Doyle inserted an array of electrodes into a cochlea of a patient with total deafness. Now what's important about this research is that the patient that was implanted was able to tell the difference between silk tearing and burlap tearing. What do you think that meant? They could tell pitch difference. So the silk was higher pitch and the burlap was lower pitch, and they could tell the difference between those two things. And so that was a really important finding. Who would have thought materials such as burlap and silk would make a difference in our lives? So certainly from that point on, a lot of researchers were taking advantage of what cochlear implants could do, and it was going all over the world. I can tell you at the University of Iowa, we started implanting these devices in the early 80s. And this is percent correct, so this is how many words patients were able to get correct who were implanted in 1980-85. these patients were completely deaf. And they were able to get 20% words correct after implantation. Now you think about that and you're like, oh, that's not that great. We were excited. And I have to say, I was only 6 at this time, so I wasn't probably that excited. But you look at this, and that was a huge deal because these patients were completely deaf. And we learned a lot from implanting these patients. We learned that maybe they weren't the right patients to implant because they had been deaf for a lot of years. Maybe some of them had never heard sound, but they were able to get 20% correct. And then over time, you'll notice that patients started getting better and better. So now we have patients with hybrid cochlear implants who are getting word corrects up to almost 80%. And part of that is because technology has changed, but the biggest part of it is we're implanting better people. So we understand where cochlear implants are going to help people better. Okay, so we look at that and we say, well, somebody who lost their hearing at age 3, never wore hearing aids all their life, and they're now 57, and they come to us and they think that they would like to hear with a cochlear implant, might not be a very good candidate for a cochlear implant. The reason, I always tell patients, if you think about, if I break my arm and I get my cast off and I don't use that arm, and then 15, 20, 25 years later, I decide I'm going to go pick up that 10-pound dumbbell. My arm's probably not going to work because it atrophied and just kind of disintegrated away. And that's kind of how your ear works. So we understand that now. And certainly outcomes with cochlear implants have gotten better over the years. So there are lots of different types of users. Patients who get one cochlear implant, but they have no hearing or hearing trouble in both of their ears. We call those unilateral cochlear implants. Bilateral cochlear implant users. So they have hearing loss in both ears, and they get 2 cochlear implants, whether they get them at the same time, which is simultaneous, or they get them at 2 different times. We call those sequential. They got them sequentially. Or they get 1 cochlear implant, but they have pretty decent residual hearing. These patients, maybe they're bimodal, so we had somebody ask a question about, can you wear a cochlear implant and a hearing aid on opposite ears? Those patients are called bimodal, so they have enough good hearing in their other ear that they still can use a hearing aid in that ear. And we call them bimodal. Then we have patients that are single-sided. So this was another topic that Dr. Roche talked about, where they have complete deafness in one ear, they get a cochlear implant, and then they have normal hearing in the other ear. And this is a collaborative project that Dr. Latovsky and the University of Iowa are going to start collaborating on. And then finally, this acoustic and electric in the same ear. So this was the topic where the patients had decent low frequency hearing, and then they had high frequency hearing loss. Okay, so in these patients, we put in one of those electrode arrays that are shorter, thinner, and we try to preserve or not damage that low frequency hearing so patients can hear electrically with the cochlear implant for their high pitch information and acoustically for their low pitch information. So they wear a hearing aid and an implant in the same ear. Okay? So these patients use standard devices and these patients use short devices. So going on, this was a patient who had that low frequency hearing and high frequency hearing loss, and everybody kept trying to fit her with a new kind of hearing aid. It just wasn't working, and so we knew we needed to come up with a better solution for these patients who had this kind of hearing loss. The hearing aid was amplifying low frequency information that they didn't need to have amplified, or they needed to have amplified, but they also needed that high frequency information that the hearing aid could not provide. And so this is where the short electrode came about. Again, patients wear acoustic hearing and an implant in the same ear. And the benefits are quality of sound. So the patients really like having that addition of natural low frequency information, acoustic information, hearing aid information that they're used to, combined with their electrical information. So we know it improves the quality of the sound. Speech perception abilities, or the ability to understand speech. Understanding in backgrounds of noise, that is improved. How many people with hearing loss do you think have a hard time understanding in backgrounds of noise? Yeah. Recognizing melodies. Because we're preserving that low frequency information, it allows us to still take advantage of the timing of music, but the high frequency information allows us to understand what words are being said in the music. So the combination of those two things helps with music. And then maintaining localization abilities. If we can keep the low frequency information, patients still will be able to tell where sound is coming from. Okay? So when we have that, these patients receive a cochlear implant, and then they wear processors that has the cochlear implant and the hearing aid built into the same technology. Both of these devices are two different companies that provide the same type of stimulation. And everything is programmed with one type of software. Okay, so it's really integrating the two worlds, cochlear implants and hearing aids. So how it works is the acoustic component, or the hearing aid part, amplifies the low frequencies that we are able to preserve, and then the electrical part stimulates the high frequencies. So what do we talk about? Well, here are some common things that people ask us when they come to us and they want to know if they're a candidate for this type of technology. How do I know if I should consider a hybrid for my patient? So this is from an audiologist perspective. Are there people I shouldn't consider for a hybrid? And other questions, possibly. So let's first talk about how do I know if I should consider a hybrid? Well, these are all the things we really have to think about when we want to determine if you're a hybrid candidate. We want to look at your audiogram. We want to look at other medical considerations. Do you have maybe an autoimmune? Do you have, what are your lifestyle and demographic demands? What's your hearing history? So that's actually a really important one. We want to get as many hearing tests as we can over time, because we want to see, is your hearing progressively getting worse? So we want to look at that, because if it continues to change over time, and when I say progressing, in the last 6 months, has your hearing loss dramatically changed? Has the low frequency information stayed stable, or has that gotten poorer? Because we don't want to implant somebody, preserve that low frequency region, and then their low frequency hearing naturally drops out because it was already doing that before they got implanted. So we would want to look at hearing tests over time to see what the progression of hearing loss is like. And then of course we want to look at speech understanding scores. How well do you perform? Because we don't ever want to implant somebody who we think will do just as well with their hearing aids as they would if they got a cochlear implant. Because certainly there are risks that go into cochlear implantation. So we look at the audiogram. These are the audiograms for two different companies. They're very, very similar. So all of this region in the red and purple, you can have a threshold, or the lowest level that you can hear something, detect something in that region, and then it really drops down in the high frequency region. Okay? Speech understanding. We use word tests. So all of our clinical trial has been based on words. How do you understand the word bat, cat, dog, ball? We look at what percent correct you get, and these are all in quiet. But, and then we use the best aided word score. What about sentence scores? Because we talked about that with Medicare. So Medicare requires you have 40% or poor using a sentence test score. So we still want to look at candidacy based on those word scores for hybrid, but to qualify a person for insurance, we have to use sentence scores. So we do sentence testing, and that's oftentimes in backgrounds of noise. We don't live in quiet environments. We live in noisy environments. And so we test in noise because that is probably the biggest reason you came and are seeking a cochlear implant. Okay? So hearing history or etiology. We already talked a little bit about this. Is it stable or progressive? Have you worn a hearing aid? And it's really important, again, going back to that arm breaking analogy, to have used that auditory system effectively. How long have you had your hearing loss? How long has your high frequency region been profound? Those are all things that won't necessarily preclude you from getting a cochlear implant, but it gives us information about how you will progress with the cochlear implant. So it helps us counsel you better if we have an understanding of all that information. Lifestyle. How old is the patient? What is their cognitive status? What are your expectations? So again, we think about music. We think about all these different types of scenarios, and that helps us guide us in, are they a good candidate to try to preserve hearing or not? I can tell you we implant patients with hybrids, in the 70s and the 80s. But it is something we think about because we want to make sure that cognitively that patient is going to be able to combine the electrical and acoustic information. We want to make sure that they're able to understand that there is a learning process that goes along with this. Medical considerations. If you don't have low frequency information, we're not going to want to give you a hybrid cochlear implant, but we might consider you for a standard length or the longer cochlear implant. These are some other things that we might consider for different types of cochlear implants. So when Dr. Roche was talking about a long electrode versus a short electrode, these are things that we think about in determining which way would be better for you as a hearing cochlear implant candidate. Counseling. What happens now? Let's pretend like we're going to implant somebody with a hybrid. The first question you might ask is, well, what happens if I do lose that low frequency information? We want to counsel patients on that's a possibility, but we have a plan for it. So we have a plan A, which is you keep your low frequency information. We'll provide both electric and acoustic information in the same ear, but if you lose it, you don't have to have that cochlear implant taken out and a longer one put in. We can change the way we're programming that cochlear implant to still work with your hearing loss. Okay? So we talk about there are 3 types of outcomes. You can have really good hearing preservation. You can have some, so maybe you lose a little bit of hearing, but you still have some hearing that we preserved, or you can have a loss of all. But those 3 scenarios doesn't necessarily mean that you're going to do poorly with speech understanding. Okay, so they're not related necessarily. If you lose your hearing, you could still be performing way above the median. So the median is kind of the average of where people are performing. You could still be the superstar in that group. a lot of it will depend on all those different circles that I talked about, who is a candidate, okay? So we plan for all outcomes. And again, you don't have to necessarily have one taken out and another put in. And the expectations are pretty similar to those who have traditional cochlear. 3 minutes? Wow, let's just move on. Your brain, again, will combine the information, but it may take time. It may take less time than if you got a standard electrode. Every single person is different, and we will guide you through that process and help you as you progress through hearing with electrical stimulation. So outcomes, we do a lot of hearing tests. We do hearing tests preoperatively at initial activation, 1 week, 2 week, 3 week, 1 month, 3, and annually. So you'll see that there's a lot of stuff that goes on right after you get your cochlear implant. Those are all really important times for patients to come back because their brain is getting used to a cochlear implant and will help them as they learn to hear with electrical stimulation. So our longitudinal data. So this kind of goes back to the lady who asked earlier, how do people do over time? It's not quite the same question she asked, but hopefully it'll lead into some answers. So we had several different kinds of electrodes. These are all short electrodes. 23 patients were implanted with this particular type of electrode, and we have data through 15 years for them. We have 14 patients who are implanted with another kind of short electrode, and finally 14, and they have up to 7 years. So this is kind of a busy slide, and I apologize for that, but these are all outcomes. So each one of these lines is a patient's hearing over time, okay? So this is all different post-implantation times. We have pre-initial activation, 3 months after cochlear implant activation, 6, 1 year, 2 year, 3 year, and so on. So you can see some patients have outcomes out through 15 years. This is loudness. So this is how much of that low frequency information they kept. And so for these patients, anybody above this line in this area still has preservation of hearing where they can utilize a hearing aid with that electrical stimulation. So I know this is a busy slide, but the biggest thing is that you understand that for 15 years, 83% of the patients who were implanted with a short electrode maintain hearing in the low frequency, that they could still combine that electrical and acoustic information. For that other electrode, 92% of patients with this particular type of electrode was able to preserve, and 85% with this particular type of electrode. This is interesting because you can see most patients will lose their hearing between pre and initial activation, if they're going to lose it. This patient was 2 years out and lost her hearing. We don't really understand why patients 2 years out would lose their hearing all of a sudden, but we're certainly doing research on that to try to have a better understanding of what might be going on in that inner ear that would cause that type of hearing loss. This is just the average over time. Again, the average for patients over time is very good. So this is basically taking all those lines that I had in those other slides and put it into averages. And so for each of these 3 types of cochlear implants, patients are able to maintain good low frequency hearing over time, which is always a big question that patients have, is this a hearing solution that I will have for a long time? And I think this research certainly supports that. So I don't want to talk about that because I probably have like 6 seconds. So let's just look at this slide over here. If we have preoperative hearing, which is for these different electrode types, you can see each of these patients are able to perform significantly better than they were preoperatively. So these patients were getting around 30% before they were implanted, and they're getting anywhere from 70 to almost 90% understanding after implantation. So it makes a big difference in how these patients are hearing. This is in noise. And in noise, these patients were getting about 20% before they were implanted, or 10%, and now they're getting 50 and 60%. So that is huge. When you think about these patients not really understanding anything in noise, now they're be able to understand certainly half or more of what's being said. And I'm not going to go over this slide. So in summary, most subjects get a really nice benefit with the combination of acoustic and electrical hearing. And then even those who lose, just pretend like that one O is not there, residual hearing still benefit from bimodal stimulation. So even if they lose that low frequency hearing, we reprogram that cochlear implant and we still combine it with what they're getting in the other ear, and they really benefit. They really do very well. So again, this has some stuff in it that I didn't show you because I was taking things in and out. But I really think that this gives you hopefully a better idea of some of the outcomes with different types of hearing solutions. Questions?
Time for a few questions.
Okay. Yes.
Can you talk a little more about the learning process
After the implant. So we always counsel patients.
Question.
Okay, so she asked, can you talk a little bit more about the learning process after implantation? And I think it's going to depend. We counsel heavily for every patient that it is going to be a learning process. Typically, you're not going to get to your best performance with your cochlear implant until maybe a year after you've had it. Certainly the first few months after you're activated with your cochlear implant, your brain is going to be learning this new kind of stimulation. And every single couple weeks, we see patients at initial activation, 2 weeks later, at 1 month, 3 and 6 months. During that time, patients are getting used to the cochlear implant, and then they need to come back so we can program it again and give them more sound. At first, patients don't want a lot of sound, and so we're able to give them more sound as they get used to it. Some patients at their initial activation will say they hear chirps and beeps and different kinds of, maybe they'll say, I think it's Darth Vader talking underwater. Doesn't sound anything like I remember hearing. Then some patients will come in, and after their activation, they can call their family members and tell them how their activation went. And they can hear some of the words that family is saying. So there's a lot of variability on what patients will be like at initial activation and how they will progress. But certainly we tell patients wear the cochlear implant all waking hours. If you hear beeps and chirps, we want to make sure that you have the cochlear implant turned up so you hear those sounds. We had some patients who got a cochlear implant on one ear who were deaf, and they had normal hearing on the other ear. And we asked them, do you wear your cochlear implant all the time? And they said, yes, I wear it all waking hours. I just turn it down till I don't hear those beeps and chirps anymore, and I hear great. Well, they're turning it down so the cochlear implant basically isn't working. And so we will tell patients, you need to hear those beeps and chirps. because those beeps and chirps are going to turn into real speech, real sounds. And almost all of our patients, when they come at their 6-month appointment, will say, "Do you hear beeps and chirps?" And they'll say, "No. It sounds just like I remember." Because their brain recognized and identified sounds and put it with what they remember. And this kind of goes to what Dr. Latovsky was talking about with music. They use their memory a lot. That's why patients who are adults that get cochlear implants, if they do much better if they're post-lingually deafened. So after they've developed speech and language skills, they will do much better with a cochlear implant because they can remember back to what words and speech sounded like and put the two things together. For children who are implanted as babies, that's the only sound they will know. So if they wear it all the time, it'll be just like what they hear. They'll develop language and speech skills. They don't have anything to go back on to remember, but that's the only thing they've ever heard. And their auditory system is very awake and ready for that kind of sound if they're implanted at a young age. Okay, one more question. Yes?
It's not a question, it's just a comment. You know, the computer program that one can access after implantation can be very helpful.
Yes.
To the recipient.
So he's talking about doing rehabilitation. So there are lots of computer programs that are exercises for your hearing. So he is absolutely correct that going to those programs and doing exercises on your ear is very, very important. And it could speed up the process that you get used to understanding speech again. So there's different programs that'll tell you what you're hearing. And then there's also programs that can kind of test your hearing a little bit too. So they're very, very useful. And if you have an audiologist and a cochlear implant and they haven't given you some of those resources, you should ask them about those resources.
Do you ever see in the future that everything will be internal?
Yes, I do. And they're actually, they're working on that right now. So they call them TICIs, totally implantable cochlear implants. I think they're certainly moving along, and I think it's certainly nothing is FDA approved at this time, but you can certainly appreciate that there's a lot of thought that has to go into making sure something is totally implantable, because if something goes wrong, there isn't an easy external solution to fix that. So that's certainly a thought that goes along with it. Dr. Rush?
I was just going to say, one of the issues that they ran into with TICIs is there's probably going to have to be an explantation strategy for batteries, because even with current battery technology, if you charge them transcutaneously, like you might charge your iWatch or whatnot, the battery will eventually have some more charge. And so that is something that they're actively working on. They started some of this over in Australia, and patients seem to like the devices, but there's some technological limitations that perhaps Elon Musk will solve in the future.
Yeah. Ooh, good one. The other thing that I know was an issue early on was, hearing your body function. So you could, because it's implanted, I heard every single heartbeat, I heard chewing, I heard, and certainly that would be something that I know that they're taking into consideration to, find better solutions. But it's certainly on the horizon. Great question. Ruth, okay.
one more chair right there. Okay, I know I saw a couple of hands up when Dr. Dunn was taking some questions. Should we start with some of those questions? Yes, sir.
Yes, I've heard that hearing loss may lead to some sort of dementia. Have there been any studies done with these cochlear implants that they will prevent dementia or Alzheimer's or whatever you call it as far as
I'll just repeat the question. Whether there is anything known about cochlear implants possibly preventing onset of cognitive loss or dementia, given that we know that hearing loss is associated with onset of cognitive impairment and dementia. Great
Yeah,
question.
so that is an absolutely excellent question, and we are beginning some of that research at the University of Iowa, because you're absolutely correct. So what this gentleman is referring to is there's some pretty impressive research coming out of Johns Hopkins, where it shows that the degree of hearing loss could be very much related to dementia. So we don't know if one is related to the other. So does hearing loss cause dementia or some aspects of dementia? We don't know where those lines cross yet, but certainly it makes sense that some patients who have hearing loss become more socially isolated. They stay home, maybe they're not engaging with people as much as they were before. And so perhaps by addressing the hearing loss issue, whether that be with hearing aids or with a cochlear implant, might get people out into their environments more and reduce perhaps the chance of some types of dementia. So that's a great question, and we're just beginning to look at that. I know Dr. Lin at Johns Hopkins just received a very large grant where he is going to be looking at that a little bit more extensively as well.
Yes, Carol.
This question is for Camille. It's, in your topic, you talked about cognition as something that you spoke about it in relation to the hybrid.
Yeah, to candidacy.
So my question is there more work the brain has to do to integrate the acoustic and the electrical
Yeah.
sound combination than there would be for an individual that's receiving the standard cochlear?
Yeah, and I think that's the
I'm
idea.
just going to repeat the question, sorry. If I remember, cognition impacting. It's really a follow-up question about cognition and how the brain can integrate acoustic and electric hearing.
Yeah, and so what she's referring to is I had a slide and I said, here are the things that might be contraindicated for patients with hybrids. And one of those things that I listed was cognition. And so we want to take that into account because one, there is an integration of two very different kinds of signals. And so if that patient is cognitively impaired, it might be harder for them to integrate the acoustic and electrical information to make one sound percept. Okay.
Thank you. And I also want to make sure everyone knows that we have our other two local clinicians and experts, Bryn and Jennifer, who, again, like Camille, have their boots on the ground in the clinic every day in audiology and in speech and rehabilitation. So please feel free to ask them questions as well about what you might expect. Yes?
In terms of a patient, I don't know who will address this question, who have heard well with the cochlear implants earlier on, but then seem to have a decrease in their hearing. I know they can be reprogrammed
about soft failure.
Yeah, do that. Go ahead.
So there's a lot of different things that could be at play here. There could be central nervous system factors. One issue that comes up routinely is how well is the device functioning, the internal device. So there can be hard failures, which is a recognizable and diagnosable problem with the device, where you interrogate the device with the processing software and find out that there's an electrode that's not working or whatnot. One cause of that could be the electrode extruding from the cochlea. In other words, you put an electrode in, and slowly over time, for whatever reason, that electrode starts to work its way back out of the cochlea, and so you lose a number of electrode contacts. It's usually diagnosable with either imaging or simply with the fact that they are no longer able to get meaningful perceptions from certain electrodes. Other types of device malfunctions, such as we term as a soft failure, which is that a person who has been a good performer in the past is now no longer able to get the benefit that they are expecting, and the device from a electrical diagnostic standpoint appears to be functioning. But what we've found is that many of these devices have very small failures in various parts of the components. We only find that out with explantation. So that's a conversation that is typically involving both the patient, our audiology and speech colleagues, as well as the company, because they will often come and try to troubleshoot this. But then sometimes the device needs to be taken out and a new device put in. And many times, if it is a soft failure, which then they can find when they take the device apart, with a new, fresh device, they will often regain some, if not all, of their performance characteristics that they had previously. So that's at least one reason, or some reasons from a device standpoint, why an individual may perform well and then over time not perform up to what they would like.
And clinically, if the device is working fine, and we don't see any change in electrodes or map settings, certainly then we think about cognition and central processing. That perhaps the speech perception is getting worse or changing over time not because the device is malfunctioning or changing, but because the brain is interpreting the signal differently. We can also see changes over time if there's just change in medical condition. So change in medication, sometimes we'll see it after major surgery or major health issues. Those are the things that I can frequently see just clinically as well.
Can those rehabilitation programs that you're talking about, can that impact at all? I mean, because obviously if you have electrode problems or mechanical problems, that sounds like that's something that can be diagnosed. And then if you have medical problems, those are sort of known after. Are there any like softer issues that, like the rehabilitation program, if you do that, would help? Or
So certainly I think those would definitely be worth a try. I don't think there would be anything wrong with giving more direct attention to that auditory system through a rehabilitative nature would not hurt. It could only help. Certainly if there's devices with the internal device and we have to remap, meaning we have to reprogram how the device is working, then I think that's another retraining issue. So some of those rehab programs become helpful or can be helpful. Yeah.
Thank you.
What are the current recommendations, excuse me, for young children, say, implanted, well, children of any age, but in particular the youngest children who are implanted, in terms of auditory training and follow-up by educators and people who are in the early childhood programs? Because it is my perception that things are falling through the gap.
Sure.
And if you have any comments about how we can try to improve that, that would be helpful to hear also.
Yeah, definitely. So I'm a speech pathologist at the Children's Hospital, and I work with some of the preschool-aged children with cochlear implants. And my recommendation is always to do regular, frequent speech therapy. And the reason for that is that kind of consistency with some of these strategies over time is really, really important for skill development. And really early on, a lot of my role is kind of helping with parent training and giving them things that they can carry over into the home to help kind of firm up some of those skills and facilitate progression along the auditory learning hierarchy. So just like with wear time being really consistent, practicing those skills is really, really consistent for adequate learning.
Can you, just to follow up, can you be a little more specific about what you mean by regular?
Weekly, for sure, if not more than once a week. Because again, it's practicing every single day during all waking hours that's so very, very important. And these kids are changing so rapidly that having a provider who's seeing them at least once a week so that you can help to kind of change things as they progress and really counsel families appropriately, I think is really important.
When they're school age, then do you communicate with the school, with the teachers?
Certainly, yeah. So I will communicate with school-based speech pathologists regarding recommendations, ideas for therapy, that sort of thing. But a lot of that kind of ongoing care is happening exclusively in the schools. For the most part, in clinic, I'm seeing the kids before they hit school age.
We're often partnering with the schools to come up with individual educational plans for individuals and all levels of care. To make sure that everyone from the surgeon to speech pathologist to audiologist to their school to their teachers to what's available to them in the schools are all on the same page with what strategies we're going to undertake. So it's an open area of communication as much as possible.
Certainly.
You have another question, right?
Yes. Are there any medications that affect hearing? And it's another one, if a person does have a cochlear implant, is there any medications that would interfere or cause damage of hearing by taking these medications? No.
Question is, are there medications that would affect hearing, or if you have a cochlear implant and you take these medications, they would interfere?
Certainly, there are medicines that can affect hearing in general, and so maybe I'll address that first and then address cochlear implant specific. So there are certain types of antibiotics, certain types of diuretics for water pills that can cause either temporary or permanent hearing loss. There are certain chemotherapeutics that can cause hearing loss. If someone has retained hearing after a hybrid or any type of hearing preservation surgery, certainly taking these medications can put their residual hearing or their preserved hearing at risk. Wouldn't necessarily be different with a cochlear implant. Although typically speaking, people who have a cochlear implant probably have very little cochlear reserve, and so what may be a trivial loss or a very, maybe that's the wrong word, but maybe a loss that doesn't result in significant communication deficit for someone with relatively normal hearing may result in a very large dramatic change in someone's capacity to understand spoken language with their acoustic component. As far as cognition, the main medicines that I think about when it comes to someone who has a cochlear implant are typically medicines that are going to affect cognition. So any medicine that's going to cross into the blood-brain barrier and affect their arousal, their attention, and their memory is something that could have a deleterious effect on someone's communication and their rehabilitation.
Now, could you describe what these medications would be?
Certainly medicines that are anticholinergic medicines can, so antihistamines, certain types of antihistamines are going to cause a decrease in arousal state. So from taking a slightly different perspective, for people who have a vestibular injury, there are medicines that people will often take that they think will help with that, but can actually block central compensation. So antihistamines would be one example of those. As far as I'm aware, there's no medicines that per se should have a negative impact on the implant, the device itself.
How do you take the stigma out of hearing loss? Because there are many, your quoted number for people who have hearing loss, but they would just prefer to keep it an invisible disability.
Yeah, no, I agree, and that is, I think there's a couple different issues maybe with that statistic and making people aware that there are solutions, and even audiologists, even speech pathologists, even your ENT doctor. I think, we've talked so much about how indications for cochlear implants and such have changed but making sure that those resources are aware of the changes so that they can get that information to the patient is one problem. The stigma, certainly with, we have patients come in and they'll say, I have to wear that thing on my head, and so that, I don't know how to get over that barrier. Certainly one thing I always tell them is, do you think you stand out more when you say, I don't understand you, or you answer a question that is not related to the context of the question, you answer it wrong? Do you think you stand out more doing that, or do you think you stand out more because you wear a cochlear implant and you can hear? And I always try to tell patients, turn that into something good. Use the fact that you have a hearing aid or a cochlear implant to teach somebody else how it can be beneficial. But it's a really tough thing, and perhaps you guys have other thoughts on that.
I think education and advocacy.
I think so too.
Yeah.
It's making sure that, certainly I think it's when I'm meeting with patients, I typically try to provide as much realistic teaching about what these devices can accomplish. The other thing I'm hopeful about is that the social acceptance of wearable technology is starting to become higher as people wear Bluetooth devices for their phones. And so my hope is that over time, the wearing something externally to help you hear will become something that is much more accepted and seen as part of the norm as opposed to the exception.
And I think another thing, with kids, it's becoming much more acceptable to bling out your device. So let that child, teach them it's okay for that device to stand out, and not that you want to draw attention to your child, necessarily, but teach them that device, you should not be ashamed of it. You should be proud that you have that device, you're able to hear, and you are a success story.
Just a family counseling piece of things that I've encountered before as well, kind of giving the child a script if someone points out the device or they experience some sort of negative interaction, giving them words to kind of describe exactly what it is to sort of help destigmatize it by giving them those strategies.
It's really surprising to me too how many people feel like they're the only one.
Yeah.
I'm the only one with the hearing loss, and they've not met other people with hearing loss. So I think support groups and getting them connected with other people, it's really amazing how many people come into the office and say, I'm the only one in my family, I'm the only one at work. They don't see other people with hearing loss, and if you can get them connected with other people, I think that's really important.
Sort of a follow-up on that, in terms of individuals who might be a candidate, but they're hesitant about like the rehabilitation because they think they're too old, if they have normal cognitive function, any information or advice how you might sort of encourage them, like, hey, you might want to explore it, the learning processes, it may be what you believe it to be so involved that you can't do it. Because again, to stand out from not being able to hear is pretty devastating from their family members or their friends.
I think that you're exactly right. There's a fine line with trying to help a patient have good expectations that it is going to be work, but also having them have expectations that it can work though. This isn't overwhelming. This isn't, that's a very good point actually, because I think we tend to try to underscore the benefit that they're get, set them up for the work it's going to be, and perhaps in doing that you might actually be deterring patients for that challenge, and so that's a good point. But I think again, going back to what she was saying is give them resources, because sometimes we've had patients come in and say, I was so scared, and then I talked to Bob and Bob said he's doing really well with his implant, or I know June, and June does X, Y, and Z, and so those resources can help push them to that next level.
Yeah, I think my experience with this has been that people are if you can put someone in contact, if they're willing, so events like this where we have individuals in the community who've undergone the implantation process and can speak to this and provide real world context for what this is going to be like, can be very, very valuable for patients. Word of mouth is an incredibly powerful motivating factor. I mean, I've seen many patients who know someone who's had an implant. It's made a big difference in their life and are now here to explore an implant. And maybe they are a candidate, maybe they're not. But it's once they see that this is something that can be very beneficial and that people that they know have it and can do well with this, that can be a very powerful motivating force.
The other thing I'll add is that the talk I was going to give earlier today kind of touched a little bit on this. How much does a patient's personality play into how they do with their cochlear implant? And certainly that would, if they're motivated, if a person's an extrovert and they feel like they're not being in environments that they would like to be because they can't hear, personality certainly might play a part in they're going to be more active, they're going to use some of those resources. But if a person is more of an introvert, they're okay with staying home. They might not be pushed to try as hard or want to overcome some of the challenges with cochlear implantation or a hearing device. But I think there is a need for much more research to understand how those kinds of things play into outcomes with cochlear implants. And I think it would be important. It's important for us to understand those things so that we can counsel people better and more effectively, knowing that there might be characteristics of a patient or an environment that might lead to different kinds of outcomes to help them have realistic expectations.
I'm trying to remember from your chart about those people who had the implant and then lost some of their residual hearing. And I'm intrigued with just the idea that if you lose your I'm thinking that if you're not using your residual hearing in any great proportion, and if you lose it and then you're able to reprogram to overcome that loss, does it require a whole nother learning process for the brain to make up for, even if it is a small residual loss?
It's a really good point. And so a lot of times with the way the cochlear implant is programmed, the electrical stimulation might be, let's say 700 hertz to 8,000 hertz. And then the low frequency information through the acoustic part is maybe 200 hertz to that 700 hertz. And then all of a sudden you lose that low frequency information, and now that electrical stimulation has to get moved down into that low frequency. And so that can be hard for patients to get used to, wow, now my low frequency is being provided electrically again. I just got used to the way the cochlear implant sounded, giving me this high frequency information, so it can be challenging for patients. And so it can be, I wouldn't say a step back, but it's just another hurdle that patient might want to go back to the rehabilitation and get used to the way that electrical signal sounds again. So there might be initially, if they lose their hearing, a change in their understanding, but it would be, hopefully then they'll regain that as they get used to that new type of additional frequencies that we introduced electrically.
If you have a hearing aid in one ear and you get a cochlear implant, can you still wear the aid in the learning process, or is it better to not have your aid on and learn to use the cochlear implant?
At our facility, we want them to hear like they're going to hear right from the beginning. So we would tell them wear that hearing aid on the opposite ear and use the cochlear implant together right from the beginning, because that's how ultimately we hope they're going to hear for a very long time. So we want them to get used to that very quickly. And I don't know if some other facilities might have other.
That's kind of the $10 million question, right? I mean, there's different viewpoints. So sometimes, too, we will have them take the hearing aid off the non-implant ear, maybe just for the first few weeks, so they can get their bearings with the cochlear implant. They really learn to rely on that implant and figure out what they're hearing through it, and then have them add the hearing aid in, and then learn how to integrate the two. So, but we would never advocate eliminating the hearing from the non-implant ear for very long. If they have residual hearing in the non-implant ear and they're getting benefit from that hearing aid, we don't want to take that hearing aid away from them for too long. Usually if we take it off, it's just maybe for the first few weeks. Yeah.
So what about if you have an implant and then you get implanted with another implant? Is it better to take the one off that you had and learn with the new one?
We do. Here at our center, we do recommend that you get rid of the first side for a while and just really work with the new implant. For those of you who are bilateral sequential implant patients, you know that the road with that second implant is much different than the first. So if you can eliminate the side, your first implant, and really grind through some of that therapy and work through that new implant side for a while first, we think that is more helpful long term.
So I think we'll take one last question, and then we will transition to our patient panel. Yes, sir.
Yes, I've heard maybe a couple of individuals who could profit from maybe a cochlear implant, but they have adjusted to sign language and are very happy with that and feel they have their own community. Could you comment on something like this? How many people could profit but don't because they're happy communicating with sign language?
Can I repeat the question? So there are people who feel that with sign language they're functioning well and have a community, and so the question was, could they comment on that and the potential benefits and integration?
I would say in my experience that by the time they're coming to see a surgeon, most of the time they're at least considering getting the implant. And I think it comes down to at what point did that person lose their hearing, how much experience did they have with their hearing, and what are they trying to accomplish with that. But certainly it's an individual decision. We never push anyone in one direction if it's against what their belief system is.
I would agree. I think if that patient feels like they're functioning using sign language, then there is no reason, for them, if they're happy with that and they don't want to hear through a cochlear implant, that is absolutely their prerogative. If a patient desires to have better hearing auditorily through hearing mechanisms, then a cochlear implant would be the right decision for them if they're a candidate at that time.
I was wondering how much is there any statistics of those who choose to get a cochlear implant are satisfied? I don't know if they
for some, certainly, and maybe you could take, we would advocate if you decide to go with a cochlear implant that you try to be as oral as possible, but it's also okay to combine oral speech as well as sign language together.
And Dr. Dunn spoke a little bit about this in her talk too, that if patients come to us as an adult and have never heard They've never worn a hearing aid, never heard, and now they're 35, 50 years old and want an implant. That's going to be very difficult. And their result with a cochlear implant is going to be much different. They probably will not develop enough speech understanding to eliminate the sign language and learn to talk. So we usually really talk a long time with those patients so they know what the outcome is. We would not expect them to stop signing, that would still be their primary mode of communication.
And there are a lot of great, interesting stories about, children who start out signing and who then transition to having cochlear implants. And the interesting question is, do they stop signing? And I think many of them do, because if they become really comfortable with spoken language, they rely less on the signing. But there's so many individual stories, and that's really one of the key issues in our field is there's so much individual variability and so many needs that we try to address. And I think this would be a great time to thank our panel and to have our patient panel. Thank you so much for your expertise and insight, everyone. I know we probably have so many more questions to run by you. I would like to now invite our patient panel to come up. We have so many insights to hear from them about as well. Thank you so much.
Do you want to do that? Okay, that's not me. You excited? Yeah.
Well, thank you everyone for being here. What I'm going to do is ask questions here that we discussed with our panelists. And I want to begin by inviting each of you to take a moment to tell us about yourselves and your history and at what point in your life you received a or two cochlear implants. Welcome. Thanks for being here.
I'll start, I guess. My name's Alyssa. I'm a student here in Madison. I got my first implant when I was 2 years old, and my second one when I was 10 years old. And now I'm going to school to hopefully become an audiologist. So.
My name is Mark David, and I received my first implant at age 18. Age 18 months. And the second one at 2 years. I'm doing water polo right now, and it's great.
My name's Jackie Mihalsik. I received my implants in 2014. I'm a bilateral. I had them both done at the same time, and I had developed a hip infection, and they gave me vancomycin, and the vancomycin made me go deaf. I think they're great. I was blessed with hearing again.
Hi, I'm Pam Holmes. I'm Director of Consumer and Regulatory Affairs for Capital Customer Service. And I began a hearing loss at the age of 13. Got my first and only cochlear implant 4 years ago, and went from 0% comprehension with 2 new hearing aids to 95% comprehension in a quiet listening environment.
Wonderful. Thank you so much. Maybe we can begin by asking you to tell us a little bit, what is it like when someone asks you about having a cochlear implant?
So I'm obviously going into the audiology field, so I really like educating people about cochlear implants, and I like people to ask me a lot of questions because the general public might not know too much about them. So I really enjoy answering questions for people, elaborating, telling them all about the different parts of the cochlear implant, what they can and can't do, and just telling them about the options and stuff like that.
Yeah, same here too. Most people will just ask me, well, what is that on your head? And I tell them that it's called an implant. It's much different than a hearing aid because lots of people call them hearing aids because they're more acquainted to that. But it's completely different. And I tell them that there's a processor and a battery, and that I have a magnet in my head, and then they get all interested. Yeah.
Pretty much the same thing for me. I love to advocate about it, and also sometimes I do not hear everything, so I tell people right away if I answer you weird, or didn't answer your question, I have cochlear implants, and that's usually the way the conversation starts. And then I'll show them, I'll ask them if they've ever seen them, and we usually go from there.
I like to share unique situations about my implant. The day I have an umbrella and it's windy and the cochlear implant gets stuck to the umbrella, or when I first got my implant, the first 4 months I wrote a blog where I explained. On day 1, I heard the dog's tag as he walked across the room. I thought that was so exciting. On week 2, I learned that the doors in my house are very squeaky. So I would share those type of life experiences. My favorite one, though, is when I'm using Bluetooth with my implant, I can walk away from my office and be in someone else's office and in my ear hear that my phone is ringing. So I share those type of experiences.
Thank you for that. Now, how would you describe the quality of the sound that you receive through the cochlear implant, and any changes you might have experienced that came up today? And it would be great to hear your point of view on that.
So I had severe to profound hearing loss since birth, so I really didn't have any experience with normal hearing. So my implants sound very natural to me. And I know, sometimes you hear those simulations of what a cochlear implant sounds like. That's not what it sounds like to me. That just sounds really weird. It sounds very natural, but I know that if any normal hearing person were to get implanted, it would sound quite different and quite degraded from what you guys normally hear.
Yeah, here too. It sounds amazing. Yeah, I've had them since I was born, pretty much, and yeah, I'm able to understand lots of things, yeah.
When I first had my implants, I was just hoping to hear sounds because that's what they tell you. And I kind of said, okay, I hear sounds, but on my activation day, I actually heard conversation. And it sounds pretty much the way that I remember. I mean, before that, I was getting prepared, so I was asking everybody, what Disney character you want to be, because they say it's very electronic. And so everybody just told me, I want to be Goofy, I want to be Mickey, I want to be this. So I kind of, that's the way I do a lot of things, is with humor, and I think that really helped me.
Before I got my implant, a lot of people warned me. They said, Pam, at first you're going to hate it. I'm going to hate it? Well, why should I do this? And then they said, you have to be patient. You're going to hear a lot of odd sounds when your brain is learning to comprehend again. So at first, everyone, male and female, sounded like Donald Duck. And that went on for a series of weeks, to the point where today voices sound like, human voices in front of me sound like I remember. TV and radio sounds more mechanical, and I'm always fascinated with why am I having no problems understanding the voice in front of me, but listening to the radio or listening to the TV is more of a challenge. So there is a difference.
Mm-hmm. So that brings us to an interesting question that also came up today, and that's music. So the first question is, do you listen to music? Because maybe not everybody does. And if so, what type of music do you like to listen to? And I'm always interested in whether there's technology with the cochlear implant that you like specifically in terms of how you connect with your device.
So I definitely listen to music. I listen to it a lot on bus rides or just walking to and from classes and stuff like that. And then I really only started listening to music for enjoyment in 8th grade. So that was when I was 13 or 14. And I'd had my cochlear implants for quite a long time, 11 years or so already. So it definitely was an adjustment, learning to like music and enjoy music as something to listen to. But I definitely enjoy music more if I know the lyrics and I can follow along to it. I don't really follow along to the instruments or something like that. I can't tell if there's a drum beat or anything like that, but I definitely follow along to the lyrics. So that would be kind of the type of music I like listening to.
And how do you plug in? Do you have a plug or Bluetooth? How do you?
So my one of my implants has Bluetooth capabilities, but I don't use it right now because I don't have the remote that it connects to. So I just have my Beats headphones that I'll listen to.
Oh, so you just put on regular headphones?
Yeah.
Yeah, I love music. I listen to it whenever I can, and type of music that I like is the pop genre. Yeah, and I just use over-ear headphones.
Over-ear.
Yeah.
I love all types of music, and right now it's hard for me to hear music, but I have seen improvement. One of my friends used to listen to the Jersey Boys all the time, and I think I heard that CD of his at least 1 million times. So I started to be able to hear that. I've tried some recently of songs that, like the familiar songs that you know and you know the lyrics. It seems to be the best. But people don't sound like I remember. And like a tune will be okay like the first few measures, but then after that it kind of goes haywire, and I'm competing with what I remember. So it's hard for me to sing right now. But one of the people that I go to, the support group with the cochlear implants, she actually heard Christmas carols the first time this past year. And she's had her implant, I think, for 4 years. So I have hope.
Absolutely. When I was growing up as a hearing individual, I was in choir all my life. I thought I wanted to be a music teacher. I suppose I still could be today, the same way she can become an audiologist, right? But my experience is I can listen to instrument music with no words and enjoy it. But when I listen to music with words of songs that I don't know, like they've said, can't comprehend the words. But if I have the lyrics in front of me, it's a beautiful experience.
Thank you. Mark David, I would like to ask you if you play any sports and what that's like with your cochlear implant.
So yeah, currently I am playing water polo right now, and the cochlear has a over-the-ear encasing you can put the implant in. And I get in the water and I put a water polo cap on, and it stays on just well. Really good. And yeah, so it just sounds a little bit like there's a little bit of electrical noise, but it gets better because the microphone's rubbing against the thing, but it gets better, yeah.
So you prefer to have your implant on when you're playing sports? So
yeah, it helps so I can communicate with the team.
Yeah, that makes a lot of sense. Would anyone else like to talk about activities where you have to kind of worry about your implant getting wet?
Yeah, I can. Mine's kind of along the same lines. I was a lifeguard, swim coach, swim instructor. I was on the competitive swim team for a while, so I did pretty much everything you can do with water. And for a long time, I have advanced bionic cochlear implants. So for a long time, they didn't have any waterproof implants, and then they came out with the Neptune and the waterproof case for the Naida. I don't have the Neptune, and I have the Naida in one ear. So it was last year I was finally able to hear underwater. for the first time, which was really cool. Never heard bubbles before or anything like that. And I also could have that waterproof case so that I wouldn't have to worry about having to jump in as a lifeguard. I would just take off my other implant, put it aside, and then jump into the water, you know, save someone or something like that. And then also I could communicate with my swim, or with the kids that I was coaching and instructing as a swim instructor. So that was really helpful. And then I also played soccer for a long time, and the only thing with cochlear implants is if you're in a little high impact sport, you know, they might fall off sometimes. And I have implants that don't really stay on all that well because they don't have what you have, kind of like a wraparound thing.
Mm-hmm.
So I would always put sports tape on my implants to make sure that they stayed on. So yeah, I think that's all I have.
Mm-hmm.
I'm actually a swimmer too. I'm at the gym every morning at 6 a.m. and I have not used my waterproof cases yet, but I enjoy that quiet time. It's very quiet and it's almost therapeutic.
That's great. I mean, I remember the days when you couldn't get them anywhere near water, and you know that seems to be a really nice advancement. You know, to be able to actually go underwater with your implants if you want to, or choose to have some peace and quiet. So let's talk a little bit about, you know, how many hours a day do you actually wear your processor, or do you sometimes choose to just say, I need to be out of sound, like if you're in the pool, but you know, what about in other situations?
So I like my peace and quiet a lot. So usually if I'm not talking to someone or if I'm not in a classroom setting or anything like that, I have my implants off, which is really nice, but also sometimes inconvenient for the people around me because I know I work in the lab here, and Shelly, our lab manager, has come in and started talking to me when I don't have my implants on, and I noticed her. I'm like, wait a second, let me put my implants on for a second so I can hear you. So I would say though I probably get 8 to 12 hours a day with my implants on, and that was a lot. It was a lot longer when I was getting used to my implants, so I was wearing them a lot more when I was learning how to hear with them. So yeah.
I keep my implants on the entire day, and yeah, so I can practice more understanding things, and that has helped a lot. So I'm able to, you know, yeah, just practicing really. I just lost my train of thought.
Do you take them off at night?
Yes, I do. I take them off at night, and I charge them. And maybe every month or two, one of the implants will die. But you know, that's just that doesn't happen all the time. It's just like once, like every 2 months or something. And yeah.
I pretty much got in the habit. They said to use them as much as possible, so I do. It's sometimes they do go though, and it's every day that I remember, oh, I'm glad I have these. I affectionately call them my ears.
I am like the individual who, when you get dressed in the morning, you put on your watch. I put on my implant. At the end of the day, the very end of the day, I take it off. So I've got it on a pretty long time. But I love the advantage when there's a terrible thunderstorm outside and everybody's trying to get to sleep. I take mine off and it's blissful. So there are advantages.
Very nice. So what happens to the battery life? Is that inconvenient, or is it something that you can pretty much cope with? I remember the days when people used to have to recharge and charge them, and really every few hours you would have to put new batteries in. It's a little bit better these days.
Yeah, so I actually have those implants, or that on my right side, because I have an older internal processor. So my batteries only last about 4 hours on my right side, but they last 24 hours on my left side. So here's my handy dandy battery case that I always have with me. But I definitely forgot them a lot in middle school, grade school, high school. I always had to call up my parents, hey, would you mind getting out of work and grabbing my battery so I can hear? So definitely gotten a lot better with that, but that's always going to be a limitation with my older internal processor.
I always carry around at school a battery case with me, and a different battery I can put in, and I always carry those around with me. Yeah.
How long do they last? You?
They last like the entire day for me. Yeah.
Mark David, how old were you when you started to do this on your own, kind of matter of fact, I carry around my battery case with me instead of, say, your teachers, your parents?
I'm gonna say about 2 years ago. 3.
And how old were you then?
Like 9 or 10. Yeah.
So around the age of 9 or 10. Yeah. And did you want to do that, or were you pushed? Did people say, come on, you gotta start doing it?
Yeah, the latter. Yeah.
if we're being honest.
Yeah.
Mine lasts pretty much towards the end of the day. Sometimes they do die on me. So I just tell everybody my ears are dead, can't talk anymore. And but I do have the non-rechargeable. There's like everybody else has. There's where you can put non-rechargeable batteries, and you just pop them in and change the bottom, and you're set to go.
I have a habit every night of getting out my charger, putting the batteries in, charging them whether they've expired or not. And I'm always carrying like the non-rechargeable batteries just as backup.
I'm guessing you don't need as many as I do, though.
I can show you a little bit.
So tell us a little bit about your use of the telephone. What kind of telephone do you use, and do you like to use the telephone? Or, I mean, nowadays you can Skype and FaceTime with people as well, which might make it easier.
So I struggled with the telephone for a really long time. I hated using it, even with my family. I would never pick up the phone, and then as I got my own cell phone, I started having to use it a little more. I'm very comfortable with answering my family and close friends' calls if needed, because I know their voice very well and I don't necessarily need to lip read them as much. I have had to call insurance and stuff like that as I entered college, so I've learned how to hear better with people that I don't quite know as well on the phone. But I do like FaceTiming my family a lot, especially since we're almost 2 hours away now, so.
So I use a smartphone to talk most of the time. And about a year ago, before that, I really only preferred texting or emailing or something like that, because, it's a lot easier for me to read than it is to, hear. But now I love talking to people over the phone. Yeah.
Oh, good. Call me sometime.
I have a hard time with the phone sometimes. It depends on the person and their tone in that, and the speed in which they talk. Everybody always tries to talk louder, which doesn't really help. It's if you enunciate, and I try to enunciate more now anyway. But Cochlear does have a mini mic, and I've been trying to use that, but I've had some issues with that, and Cochlear's going to get back to me on that. It seems like other people, sometimes I think they're on headsets and they tell me they can't hear me, because I've tried it with other people that just have their cell phone with them and I can hear fine and they can hear me. But when you're making a business call or a call to the insurance or something, for some reason they have a hard time hearing me on that, so I have to turn it off and just I tell them I have cochlear implants, and most people are very nice about that.
I grew up in a house of 4 girls, and my father had a schedule on the wall because we would argue about who was going to talk on the phone when. So the telephone is a very important part of my life. I used a caption telephone when I was using hearing aids, and more recently I'm using the phone clip from Cochlear America with the Bluetooth in my caption telephone. And it's just awesome because, especially on conference calls, I can actually hear and understand the speech. It just blows me away because that wasn't always the case. And so the combination of Bluetooth direct to the ear audio plus the captions, I also am brave enough to use my iPhone without captions in my car. There's something about those car speakers that I can have a conversation driving home from work. I just love it. Couldn't do that before.
That's amazing. I want to ask you one more question before we open this up to our audience, because this also came up earlier. Do you know other people who have cochlear implants, and is that an important thing for you in terms of your day-to-day support system?
So I actually have two friends within the same family who have cochlear implants. And we really only met because the older girl and I had our first cochlear implant surgery on the same day. So our parents connected, and our family became mutual friends. And then the younger girl, when it turned out that she was deaf or hard of hearing too, she ended up having both her implants implanted on the same day as I got my second implant. So it was a really huge coincidence. But yeah, they live in Chicago. I don't get to see them much, but when we do, we always compare experiences and stuff like that. But I love meeting people with cochlear implants like I have today. So
yeah, it's always fun to talk with people with cochlear implants and just compare experiences, the annoying, the good, the bad, everything. And I have a couple friends from Child's Voice. Yeah.
Can you tell people what the school is, Child's Voice?
So Child's Voice is a school that hard of hearing kids who have cochlear implants or hearing aids will go to. They focus a lot on speech and learning. Yeah.
How old were you when you started going there?
I think 3.
Mm-hmm.
Yeah.
Yeah, it's holding up his fingers in the audience.
Yeah.
Wonderful.
I think it's important. I go to 2 support groups. One's Cochlear, and you can talk to Carol if you want to know when the meetings are in that. And also the HLAA, the Hearing Loss of America Association. And you really get a lot of good support. There's a lot of new information out there. I mean, technology is changing, and they keep you updated on that and posted what's going on. I think it's very important.
I have 2 co-workers that have cochlear implants, so we've done things like, my battery's dead, do you have one? It's very helpful. But I know people nationally, in the national community, who little by little, where they were resistant to getting cochlear implant, they each had a positive experience and shared it, and it influenced many others. Where we started to see, I think earlier the speaker was showing the word comprehension that you get and how it's improved over the years. That's what motivated me to do it myself. When I saw getting 20% speech discrimination gain, wasn't that excited, but when I started to hear about people that were getting 60, 70, 80, 90% comprehension, that's where I said, this is what I want to do.
Mm-hmm. Well, you're all amazing users of your cochlear implants, and I'm sure that our audience has a few questions for you as well before we break up in the day. Yes, sir.
Yeah, I was just wondering how having cochlear implants, loud noises affected you, because all of a sudden, they affect me too. And like I know I went to fireworks once and I saw these little kids put their hands over their ears. I had to get into the car, it bothered me. So I was wondering with cochlear implants, how does loud noise affect you?
So the question was, with cochlear implants, how do loud noises affect you?
So the example that you used, fireworks, I always take off my implants for that because I like sitting on the ground and feeling like the sound of the fireworks or feeling the vibrations of the fireworks. So that's actually kind of an enjoyable experience for me, just taking them off. They can be annoying as with any normal hearing user, but I don't think they affect me any worse, or are they any better than a normal hearing user would have.
Yeah, so most of the time I like to listen to music like high volume, and and I like to feel it, and yeah, like to enjoy it more. Yeah, like
and you don't have to worry about it damaging your ears.
Yeah, that's enough. Yeah.
Yeah, you have the advantage of loud noises. You can take your cochlear implants off and do it like that, or even like small noises you try and figure out, because you hear a lot more noises, and it's like, even in your house, it's like, what is that noise? And you try to figure out what it is, and it's hard to sometimes place where it's coming from or what it actually is. But yeah, you have that selective hearing, so-called, if you want.
When I go to noisy restaurants, and the hearing people I'm with go, I'll change to cafe mode, and it blocks out all the background noises and focuses on the person in front of me. And the hearing person with me says, gosh, I wish I could do that. And I said, there are advantages.
That's right.
Yeah.
You hit on a question I was just going to ask, because with hearing aids, I have like 4 programs, and I've never heard, until you mentioned it, somebody saying the adjustments you can make with your cochlear implant. So do you have different programs? How many? When do you use them? When do you change them?
I'm going to ask you a question. You mentioned that you have some programs that you can switch between, and the hearing aids might have 4 programs or so. So do you have different programs that you can switch between for your cochlear implant in different situations?
When I came into the auditorium, I first wasn't hearing the panel. So Carol Burns back there, the expert, she had me adjust the sensitivity for listening farther into the room, changing the volume. But I don't do that very often. If Carol wasn't here, I wouldn't have thought of it. But with the hearing aids, the cochlear implant, I was anticipating everything to get louder. It didn't work that way because my audiologist, Jennifer, is here somewhere. Where are you, Jennifer? She, when she started my mapping, she said, now tell me when it's too loud. So I think you can control how much loudness you tolerate in a situation.
Thank you. And also, Camille wanted to add to this as well.
So some of the newer cochlear implant processors actually have a program that will kind of scan the room to see what kind of environment you are in, and then it will adjust the way the sound is processed so you don't have to change programs. So it's called, so it can almost, scan the room to say, okay, you're in this kind of environment, or you're listening to music, or you're, and then it will adjust the program. So for her, where she adjusted, she wouldn't have had to do that. It would just kind of do that for you a little bit.
I have the scan program, and I'm not a fan of it.
Yeah, and some people aren't. It's what you're used to. So if you were used to not having something like that, then all of a sudden somebody putting that kind of program on your processor, all of a sudden your processor is doing something that you might not want it to because that's not what you're used to. But for patients that just start out with a cochlear implant, some of those patients really appreciate that, the ability for it to move around.
Alyssa, did you want to add to that?
I mean, I wanted to say a little bit about programs that are built into the processor a little bit because, so for my right implant, which is my older implant, I can interchange it between my right and left ear since they're compatible. So I have 2 different programs for that. So I have my right program and my left program. And then for my left ear, which is a little newer, more advanced, I have a underwater program that I have to change to for my case in order to be able to hear underwater. And then I have also a concert program that I haven't used yet, but I'm going to a concert in October, so I'm really excited to try that out. But it's supposed to kind of take out the audience noise and focus more on the singer, and it has a couple other modifications that's supposed to make it a little better. So there are those pre-programmed programs that you can use as well.
Wonderful.
There's also what she was talking about on here, maybe your question. You can change from like a cafe setting where it's not real noisy. You can change to a restaurant setting, which is a little noisier, and it's supposed to, like, the background noise is weeded out. There's also a music program, and what's the 4th one?
The scan.
Oh, the scan, yeah.
Well, I do want to say when I tried the scan, it just came out. So maybe it's time for me to go back to my audiologist and see if it's improved. My experience was you would hear the little clicking as it changed. That didn't appeal to me, but maybe that's not there anymore.
This is a question for Pam. I have a cochlear implant and a hearing aid, just like you. Everybody is answering the question about loud noises with only cochlear implants. I find noisy situations are easier for me to tolerate with my cochlear implant than with my hearing aid.
Yeah.
Do you agree?
I've done both. You mean turn it off on the implant itself?
Ah.
I do that, but then I feel like which program I'm on. This I know.
So the question was, what if you have a cochlear implant and then a hearing aid? Does the hearing aid in the other ear help, especially in noisy situations?
Thank you, because I did miss that question. That shows you that's where the other 5% is. No, see, I had a hearing aid before, and I stopped wearing it. I was always the person that always had them on, you know, morning and night, but it became so inferior. It was like, here's the implant and here's the hearing aid. It's nice that other people are having a different experience.
Tell us, we touched a little bit here and there, but can you tell us, because I'm sure only you know, what are the advantages of being a person hard of hearing?
So what are the advantages of being a person who is hard of hearing?
So, I mean, I either hear stuff or I don't. I don't have any residual hearing. So I really like that in testing situations where I can take off my implants and just completely block out noise and only focus on what's on my paper. And then we all said sleeping at night, it's a lot easier if you can't hear anything. And I just really like the education part of it. It definitely opened me and my family and my friends up to a totally different world that we would never have experienced if I hadn't had hearing loss as a young kid and done cochlear implants.
Yeah, I remember when I was in grade school, like in 4th grade, I think. Yeah, so somebody like asked me like, what is that? And I explained to them, and then you can take that off, and you don't have to listen to people. That's so cool. I wish I could do that. And, yeah, it's like do you ever like tune it out because it's annoying? You don't want to listen to annoying people. Like most of the time, I like to hear what they're saying, but you know, sometimes.
I've taken it out when my parents were yelling at me a couple times, you know.
Yeah, you can't have that selective hearing if you want it. And I look at it as a benefit because through the groups that I go to, the support groups, I've met wonderful people, and we all support one another. And it's been a difficult road, but there's been people put in my life that have really made it special too.
I agree with everything they've said, the awesome advantage of being able to go silent. But I also want to say that my hearing loss has taken me places. My hearing loss has allowed me to be at the White House, at Congress, and advocating for different rights that I would not have if I didn't have a hearing loss.
And it gave me a career too.
Yes, yes, it has.
As a future audiologist, and I used to be a previous teacher, this is for Mark Bean and Alyssa Moore, what advice would you want to give teachers to better support you in your learning that I could give as a future audiologist?
So as a future audiologist and as someone who was a teacher, what advice would you give someone in order for them to support you best in the future?
So I mean, hearing loss and deafness is such a range that it's hard to know exactly what to support one person. So the first thing I would say is to ask their parents, you know, because they're the ones who's going to know best what they need. But I'm going to say for me personally, in grade school, middle school, and high school, I never had any accommodations. I just had preferential seating, so I'd say, okay, I need to sit at the front left of this classroom because I hear better with my right ear. And then I would say, hey, you know, try to stay on my right side because that's my better side, and then try to face me more than you face the board, especially if you're speaking, because I rely on lip reading a lot more than I realize sometimes. So.
Yeah, what she just said. Yeah, it's very helpful if you just look at me and I can read your lips, because reading lips is something I do really well. Also in grade school, I also used the FM system, but I'm not using that anymore, and I'm getting the same results now because I'm doing much better at reading stuff.
That was one thing that I was going to say. There are devices out there to help teachers and to help that student. And if your school district or wherever you're in will provide those for them, it's a real beneficial. I was going to become a physical therapist, and when I was going to school for that, they actually had devices that they let me use. I had a pen that actually recorded what they said, and then I could go through later and do my notes, and there's a lot of equipment, and every day there's new stuff coming out.
And I'll add something too about my current accommodations. So in classrooms I use card, which is what this is right here, and then I also have a note taker, I have preferential seating, and what else? I have an FM system accommodation, but I've never used it because I've never really used FM system. So accommodations are a really huge part of helping us, especially when we get into higher education. So.
Yeah, and I can tell you as a teacher here, we have pretty strict requirements, you know, that we have to adhere to accommodate students. And so the system is really great about supporting students. Yeah, Pam?
Yes, my master's is in deaf education, so I taught 11 years before I changed careers. But I think one thing I would say to all teachers is treat the individual like an individual first who just happens to have a hearing loss. Because nobody wants to be singled out as different. Nobody wants to be, like, I imagine what you would go through now. I could hear when I was younger, but I just feel like stand in front of them, make sure you have your attention, that they're looking at you, but treat them like any other child in your room beyond those special accommodations. Agree?
Wonderful. Well, thank you so much to our panelists. You guys have done a wonderful job, and I want to thank everyone for your attention this morning and for participating in today's event. I think some of us will stay around if anybody has any questions, but otherwise please join us again next year or for other events, and hope you have a great rest of your weekend. Thanks for being here.